Good morning, everyone. Today's OT-2 case is an 18-year-old male who has presented with history of neck pain for last 2 years and numbness and tingling in all 4 limbs for last 2 years and weakness in right side upper limb and lower limb for last 3 months. There's also associated history of slip and fall over back 6 years back, and there's no history of any sensory loss or no history of any bladder or bowel complaints. On examination, in the sensory system, there is no sensory loss or any dermatome. In motor system, the bulk is reduced in right inner and hypothenor muscles of the hand as compared to left. There is grade 2 spasticity in all 4 limbs. Power is 4/5 in right side upper limb and lower limb, and 5/5 in left side upper limb and lower limb. There are exaggerated deep tendon reflexes across all joints. Plantars are upgoing. Hoffman's positive bilaterally, and inverse supinator also positive. So the imaging, the dynamic X-ray shows atlantoaxial dislocation, which is reducible in extension. So this is the pre-op CT. This is sagittal CT with the CT angio, CT CV with CT angio, which shows relation of the vertebrals. Shows atlantoaxial dislocation, which is reducible in extension. So this is the pre-op CT. This is sagittal CT with the CT angio, CT CV with CT angio, which shows relation of the vertebrals. CT was also done in extension, which shows reduction of AD. CT was also done in extension, which shows reduction of AD. This is the axial cut. This is the axial cut. This is the coronal CT CVJ with CT angio. This is the coronal CT CVJ with CT angio. And the VRT 3D recon showing relation of the joints with the vertebrals. And the VRT 3D recon showing relation of the joints with the vertebrals. Preoperative MRI done shows kinking at the level of cervicomedullary junction with a ADI of 5.9 mm. This is the pre-op MRI showing kinking at the cervicomedullary junction. So this is the case of mobile AED, and this is planned for anterior C1 C2 transarticular fixation. I would like to invite Professor Sushil Patkar sir for further discussion. So this is the pre-op MRI showing kinking at the cervicomedullary junction. So this is the case of mobile AED, and this is planned
Good morning.
for anterior C1 C2 transarticular.
Plan to axial dislocation, the whole thing, treatment depends upon the reducibility. This is, you have seen in extension, it is reducing. So once it is reduced, how you fix, whether you select to fix from behind or from the front, is your kind of choice, what you want to do. I am proposing a concept that it is easier to be done from the front because this operation is done in supine position with head in extension, that is the position in which it is reducing, unlike doing it in prone position. Plus, can you get a 3D reconstruction images? Like I said yesterday, the best fixation to fix a joint is to, where rotation is the predominant movement, is to pass the screw across. So when you see this, get the AP and stop it over there. Stop it at the AP. Plus, can you get a 3D reconstruction image? So when we look at this, like I said yesterday, the best fixation to, when we see this structure, if we are able to pass one screw across or one screw across this, that will have impaled and stop the rotation. There is enough bone actually to pass even 2 screws. But the first I will pass one screw from here across and one screw from here across in the extended position. And I think that should be more than enough by after preparing the joints and putting bone grafts in the joint. Can you show me that one image where I did the measurements? Is that image there? Actually to pass even 2 screws. So the preoperative planning consists of, first is where the vertebral artery is going. See, in both these cases, the vertebral artery is going laterally. There is no impedance to my part. It is nowhere in my way of where I'm going to pass the screws. The second thing is that there is a lot of strong bone available for me over here. Towards the facets, the stress lines of the vertebra are just under the facet joint. So you got very strong bone and you got this notch from which you can pass the screw across. Yesterday, Professor Visochi asked to set the question about difficulty in passing the ipsilateral screw. So once if I have any difficulty, I will drill a little bit of bone over here so that I can angle my drill properly. But it is required very rarely. You must always have a second option. You must remember that the screw must start at least 5 to 6 millimeters below and medially. There must be adequate amount of bone. Sometimes people make the mistake of starting the screw very close to the joint and the bone on top fractures. And that can end up in a difficult situation. So you must plan your entry point. And the more medial you are, the more unlikely that you will injure the vertebral artery. So take it 5 millimeters below and medial and then pass it across. On the AP, the screw should be directed towards the upper outer edge of the lateral mass. On the lateral, it should be directed towards the posterior upper end of the lateral mass. So these are the kind of 2 important landmarks where you should pass, take the direction of the screw. The single most preoperative important test is to do a lateral X-ray without any parallax to the mandible, and the mandible must be above the C2-3 disc or up in the upper part of the C. If it is going anywhere below that, then it is very difficult to do this case from the, of course, with nowadays I use the endoscope and I'll dissect and even do it under endoscope, but then that is it makes the thing more and more complex. Because in 90% of the time, you will find that the angle of the mandible comes up to the C2-3 disc or above. In this case, it is coming slightly above the C2-3 disc. They have not got the image I showed to you from the OT. So I feel that this will be relatively a very easy case to do. If there are any questions, I am ready to take them. It makes the thing more and more complex. Because in 90% of the time, you will find that the angle of the mandible comes up to the C2-3 disc. In this case, it is coming.
So there is a
tilt.
Are you going to correct the tilt by using a slightly different height of a cage on one side?
I'm not going to put any cages. In this case, you will find, can you go to the sagittal image in extension? This is an old fracture odontoid, where probably this is the distal end, as you have to remember, in all fracture odontoids, never does the distal fragment leave its alignment with the anterior arch of the atlas. The transverse ligament is invariably intact. What gets disrupted is the vertical part of the cruciate ligament, and that is what decides the instability. Now, in this case, you'll stop it over. So you'll find that this bone has been, the cortical margin reformed, a very old fracture. The idea is only to get an extension, relieve the compression, and fix it in that position.
Now I'm asking about the tilt.
Tilt off?
The C1, C2.
Yeah, the moment you open the joints and you hold the, having crutch field tractions. So when I hold the crutch field traction, that will help in correcting the lateral tilt. The idea is only to get in extension.
Yeah,
Sir,
sir.
while choosing any case for anterior approach, what are the special aspects in terms of radiology while choosing such case?
All that is said. One is that the mandible should be above. There should be no vertebral artery coming medially. There should be a lot of bone under the entry point, and these are three main requirements.
While placing the patient on OT table, what should be the optimum degree of extension at neck? How to find that this is the best position for extension?
You see, do the CM and see that you have got the reduced position of the dislocation. You confirm that you are getting the reduction on the extension X-ray, and that in that position you are going to fix the patient.
Thank you, sir.
Dr. Patkar, last time also we saw this excellent way you exposed and did the surgery. I just want to know, when we expose the joints bilaterally and we don't have your plates available, can we put something else?
You can put anything.
Can we put a mini plate?
Yes, you can put a mini plate. The plate should be more than 3. See, the requirements now of diameter over the years, any plate which is between 2.7 to 3 mm in thickness, and which accommodates a 3.5 to 4 mm screw is good enough for the subaxial spine, and same thing is good enough for the atlantoaxial dislocation. But to fix dislocation, I prefer a transarticular screw. The plate is a salvage when the screw cannot be done.
So standard transarticular screws can we put in this?
More than sufficient. 3.5 to 4 mm, even 4.5 mm.
And if we want to put a plate, we can use any mini plate and just
Any mini plate. Pass one screw in the lateral mass and one in the body or subfascial region of the C2.
Yeah, so at times, despite the angle of mandible being at the optimum level, the submandibular gland is quite bulky. So how do you manage that? Number two, do you preoperatively plan or preoperative? The problem is at times getting that angle in which the screw goes, because you may have to have a more inferior angulation to get into the joint. At times that becomes quite, there is very small bit of bone in front of the screw. So can you on the preoperative MRI anticipate this problem? Preoperative, sorry, CT, 3D.
CT, 3D CT. Always on the pre-op CT, you can, on the 3D reconstruction.
So, and even in this case, I believe that ledge may be quite small to the screw, the bone in front of the screw in the C2 will be very small.
I don't think there will be a problem, especially if there is a ledge. Sometimes this is flat, and that is the time there is a problem. In children, this ledge is not formed many times. Then there is a problem. So then you have to use a plate where you keep the plate across, put one screw over here and one screw over here. And then this new plate which I talk about nowadays is where I put one screw here, one screw here, and one screw in the center. So that's very well. So obviously when you do this, all your options should be available on the table. You can't open and then say that this implant is not there. So you have to have a plan B, plan C ready in the operation theatre. And then of course you should also be able to do good posterior fixation. If there is any problem, you must be good enough to turn the patient into a posterior fixation also. But the chances that you require that is very, very less. But you cannot go and say that I do only anterior surgery, and if now it cannot be done, thank you very much.
Yeah, so submandibular, how do you manage
Yeah, submandibular is rarely in the way. Just you can dissect it, take a stitch and pull it up. Yeah, our entry into the prevertebral space is much below the submandibular gland. It is below the digastric tendon. The submandibular gland is always above the digastric tendon. So submandibular gland, rarely, I have never encountered in so many cases that submandibular gland created trouble for me. I don't know whether Professor Visochi can add. Do you think submandibular gland has created trouble for you any time? Entry into the prevertebral space is much below the submandibular gland. It is below the digastric tendon.
At the very beginning of my experience in submandibular approach, I isolated submandibular gland, I shifted up, and someone removed it, but I was used just to shift it up. But with this new modified 3 steps technique that I showed you yesterday and today I repeat to you, I don't do that. I don't want to look for submandibular.
Correct.
Exactly as a close approach. When we perform anterior cervical decompression infusion procedures, in the book you can see that you have to isolate carotid artery, valgus nerve, jugular nerve. You don't need it. just to identify your target. But the risk of this minimally invasive approach is to have a very short mobility and a very small surgical domain. So, my question is, since we have two ways to manage this anterior approach, submandibular and closer high subaxial approach, both has the possibility to control your target, but probably the subaxial clowered approach has a more comfortable angulation to engage the surgical line. What kind of approach you choose in this case? And second question, how long is the screw? And third question, which is the X-rays target? Because I think that I suppose that you operate under X-rays guidance, not 3D neuronavigation. Which is the radiological X-ray standard target to be sure that you reached the final part of your track with your screw?
So question number one, the kind of clowards approach is good when you are doing an odontoid screw. It is not a good approach for passing the lateral mass screws because the trajectory and the distance becomes very big to reach from the subaxial spine to this point. Whereas when you go from the submandibular region, you have direct access to that area. This is the answer to question number one. The question number two was the radiological landmarks. What was question number two? There's no neuronavigation so far has got a tracker which can be put on the anterior spine. Now EasyNav is a company, they are making for me a tracker which can be fixed with pins to the C3 body. But I prefer not to dissect from above downwards because once you start dissecting from above downwards, there's a larger chance of injury to the superior laryngeal nerve. If you go directly to the body here and dissect upwards, you are not going to damage the superior laryngeal nerve. But if you work from above, because the superior laryngeal nerve comes from here, right. So if you dissect below from top, you are going to end up in trouble. Try to remain, at the C2-3 disc and try to put the tracker over here, and then you can do the navigation. Otherwise, the X-ray is good enough. Over a period of time, I don't even use the X-ray because once I see the screw going across the joint, and if it has gone more than a centimeter into the lateral mass of C1, that is more than sufficient. So, of course, but the C-arm you can always use, and you can do the lateral C-arm and the AP C-arm, the screw should be directed in this direction, and in the lateral it should be directed towards the posterior end of the lateral mass. But when you are passing the screw, when you see the screw going across the joint, immediately any movement between the C1 C2 stops. And then if you go even 10 millimeters or 12 millimeters into the lateral mass, that is more than sufficient. In fact, when you do posterior transarticular screws, the engagement in the lateral mass is much less because of the trajectory. So anteriorly, you got a bigger trajectory into the lateral mass of C1. You have to be only careful about seeing that you start adequately down and don't start very close to the joint. Many times it has happened in the beginning, I should start over and then fracture as I'm tightening, and then I'm in trouble. You can also augment it by putting one more screw from here into the vertical screw into the lateral mass of C1. Once you expose, you have to remember that the joint is about a centimeter to centimeter and a half above the disc space. So go about a centimeter. I have already seen yesterday on the CT scan that the joints are about 1.5 centimeter above the C2-3 disc. So once I dissect up, I will take and cut the longest scoli muscle on both sides. Once I have cut the longest scoli, there is nothing else but the joint underneath. I think I've answered. There's one question I missed. There are three questions or two questions. Length of screw. Length of screw is entirely based on the CT scan evaluation pre-operatively. So that we have measured yesterday the height of the atlas, what is the height of the atlas, how much when you take the trajectory laterally, how much it is, and the quality of bone also. Sometimes there's some cystic degeneration in the lateral mass. There are three questions or two questions.
Yes, and due to the uncomfortable angulation of ipsilateral lateral mass joint,
What is the height of the atlas? How much when you take the trajectory,
someone
laterally,
use
how much it is? And
malleolar
according to your bone
screws,
also, sometimes
shorter
there's some
one,
cystic degeneration in
ipsilaterally,
the lateral
and
mass.
longer one, contralateral. Do you do that?
No, I don't. I'm telling you that if there is any difficulty in passing the ipsilateral screw, what you do, hold the drill and maybe drill about a few millimeters of the cortex over here. Rarely I need to do that. Most of the time when I see a CT scan like this, it is doable to pass the screws. But if at all is any difficulty, I will take a diamond bore or a cutting bore and make a little trough over here. The difficulty is because of this hub, which is variable. Sometimes it is very big, sometimes it is flat. But in this case, if there is any trouble, I might have to drill a little bit here so that it doesn't obstruct my drill. This is another important point, that you must have an angle drill. You must always have an angle drill, which you turn reverse, so that you can hold the drill. There is angle drill which you turn upside down and hold it in your hand, and the drill bit should be at least 3.5 mm in length, in thickness, and 30 to 35 mm in length. So you must have a good drill bit. I always have 2 or 3 drill systems on the table. Metronics unfortunately comes only with one drill bit. It is a very good drill, but it is very, very small. It is only 8 mm. So the other drill which I have on table is either NSK or Ben Air, which has got a longer drill bit. Thickness and 30 to 35 mm in length. So you must have a good AP. I always have 2 or 3. I don't need to do open mouth. I'm not trying to see the odontoid. The lateral muscles are well, unless and until there is a difficulty in seeing the lateral muscle. If you tilt the Sian image, you will see where the lateral muscles are. The open mouth is important when you are passing the odontoid screw, because you have to see the odontoid.
And I believe you use fully threaded screw and not black screw.
Yes, I have got the special fully threaded screws which have been made by J-On.
Yeah.
I am comfortable with those. And they have a good hole both in the lateral muscle also and the facet also. The open mouth is important when you are passing the
Thank you, sir.
screw, because you have to see the odontoid.
And I believe you use fully threaded screw and
Who's
not black
next?
screw.
Yes, I have got the special fully threaded screws which have been made by J-On.
Yeah.
I am comfortable
44.
with those. And they have a good hole both in the lateral muscle also and the facet also.
Thank you, sir.
Who's next? 44.
Good morning. Today we are going to operate a 60-year-old male patient, a resident of Uttar Pradesh, who presented us with chief complaints of lower backache relating to dilated lower limbs for the past 15 years. The pain was more on the right side than on the left side. Now the patient started developing weakness in dilated lower limbs for the past 1 year, along with urinary symptoms of urinary incontinence for the past 6 months. The current claudication distance for the patient is 100 meters. Patient is also known case of hypertension. On examination, the patient's power in bilateral lower limb was 4 plus 5 across all joints. Reflexes were 2 plus. Babinski was ongoing. There was no sensory loss on examination. First is the dynamic X-ray of the patient, in which we can appreciate there is grade 2 L5 over S1 enteral listhesis in this patient. Then on the sagittal CT, we can appreciate bilateral parts fracture along with grade 2 enteral listhesis in this patient, along with multiple osteophytes. On the corneal imaging, we can see the vacuum sign at L5S1 level, suggestive of degenerative spine disease. This is the axial imaging. the T2 sagittal MRI of the patient. Again showing the cord compression in the diastasis. Now I would like to call Dr. Rajakumar Deshpande for telling us further about the case and the operative management. Thank you.
So good morning. This is a listhesis. If you divide this into 50%, it's just beyond 25, falls into grade 2. So it's a Meyerding glass grade 2 listhesis. And in extension, it is not reducing. The disc space is reduced here. So ideally, we should correct this for getting a nice stability. So we use a minimal access approach. Patient has symptom both sides, more on the left. So I use the side which has more pain, more radicular pain, as the site where I put the retractors, minimal access quadrant retractor, do a facetectomy on that side, and then use a sizer, that is a intervertebral disc space sizer to distract. So the key is distraction. And as you notice, in the front, there is this material. So we have to take out all the disc up till here and ensure that the whole disc is cleaned up. And then we do it. The thing about this patient is, if you go to the, can you go to the CT? And if you see the CT, wait, I'll go back. It can go back. Yeah? You run this CT, go back, go back. Yeah, you run this, you can run both. I want you to see the facet joint at L4-5. See, there is already a vacuum phenomena, so there is significant facial arthropathy at L4-5. Now this patient has both back pain and listhesis, and I'm not sure whether if we do at one level, I'm comfortable to just let it go. That's the thought process.
Good morning. I think on this one, flexion and extension view, it is really fused. So restriction what is height, I think very looks difficult. Do you have any plan for that? Maybe when we have after passage joint removal and put the cage restoration, we have to widen restore this height. Because both the lateral side and anterior side are nearly fusion stages. We have to broken and
I have some challenges today to get it to move. The fusion is a very rare occurrence in degeneration. Many times when you take out the disc and you try to use a shaver and you go in, you start getting some movement. Now, if it is already fused in this position, it doesn't make sense to reduce. I might alter the idea of just doing a facetectomy bilaterally and put screws so that it doesn't move and put additional bone in the disc space. Idea being that the foramina on both sides are open and there is no radiculopathy, no pressure on the nerve. But typically what I have seen, even though the CT scan shows an early fusion, it doesn't show a dense calcification. So many times you will find a space. And many times what I have done, if I want to get a good alignment,
I use a chisel at that level to break that osteophyte. It can be easily broken, and then you have a chance to pull it back.
Thank you.
So the osteophyte, are we talking about the inferiorly placed, which is anterior and inferior, this
Yeah.
one?
Many times I find that this is not so strong. You just put a chisel here, it can break, or even if you put a spacer, it will break. But if it is really, really hard, I won't go about breaking it. I'll do a facetectomy and fuse it in situ. In situ fusion is okay if the nature has taken a fusion of its own. I try not to do too much. It gives an opportunity to explore the disc and see whether this is a solid fusion or one of those, okay fusions.
Is it possible that we only go on one side instead of doing bilateral, in case it doesn't reduce, we are talking about, and just jack up a little bit so that it opens both foramens?
If it is already fused, solid, the facet won't move. You have to decompress the foramina completely, both sides.
Both sides?
Yeah. Idea is this foramina, the patient has pain for 2 or 3 reasons. The back pain is because of the listhesis and the facet hypertrophy. The radicular pain, claudication pain, is because there will be a compression here in the canal as well as the foramina. What happens when you are doing a listhesis reduction in the usual situation, when a distraction is happening because of the way you use the sizer, the foramen gets widened. In case the whole bone is solidly fused, it doesn't move, even in spite of removing the disc, and you have to say, this fusion is very solid, I'm not going to touch it. Then it requires a bilateral facetectomy to release the complete foramen. Idea is both nerves should be free. Once the anterior solid fusion has happened, the facet will have no role to play. You just add screws to be your peace of mind.
Good morning, sir. In this case, with the anterior osteophytes so much, would an ALIF have been a better procedure, because there is bilateral pars fracture? So once you go anterior and get a big cage, it jacks up or causes indirect decompression of the facets.
I like ALIFs in many situations. The idea of doing an all posterior approach is, in one approach you do both anterior and posterior surgery. Second, in any situation where you are planning ALIF, if there is a solid mass of bone, you necessarily either have to abandon the procedure or go and drill it off or chisel it off. So at the posterior approach, you have the possibility of thinking, look, I'll remove the disc, that whatever that portion of the disc that is there, and then I see if there is any movement. In spite of removing all the soft material of the disc, if there is a solid fusion, I know that the only way to make it up is either break that fusion and create an alignment, or accept the fusion and say, this is the best nature has done, I'm not going to touch it, I just going to add more bone into the disc space, release the facet on both sides, and treat the upper level, which is an independent part.
And you would go on both sides simultaneously? You would put tubes on both sides and then...
No, initially I'll do only one side,
yes.
and then see how it goes.
Okay, sir.
If I need be, putting the tube on the other side is not very difficult.
Right. Thank you.
Sir, how much reliance do you place on back pain while taking the patient for fusion? So this patient, if he doesn't have much back pain, would you consider only decompression?
Surely, back pain is, see, the way I look at back pain is in the following. Excuse me. The way I look at fusion is in the following. When you say patient has a significant back pain, and that's very important to understand, that the VAS score should be above 6, 7, 8 for a period of at least 6 months. And it should have failed conservative therapy. Failed conservative therapy means at least 6 weeks of physiotherapy, okay? And also patient has had good exercise regimen, and all these have failed. Third point is he should not have things like significant osteoporosis, which complicates your decision making in back pain. So if you take away the metabolic factors, if you say that the patient has a good conservative therapy, and spent significant time and say it doesn't work, and the radiology correlates with either advanced disc degeneration and or a facetal hypertrophy which is significant, then you say that is significant. If the patient has predominantly radiculopathy and a mild back pain or a back pain which settles down, I'd be very hesitant to do fusion in such patients.
Other thing is having a case in which there is you just do interbody and put screws, vis-a-vis a patient with degenerative listhesis with canal stenosis, in which you also intend to do a good canal decompression by ULBD. Do your docking changes a bit, because you have to now also decompress the canal right from one side to the other?
No need in the case where using a quadrant system, because it allows for some movement medially. Depending on how much lamina you do, if you're drilling up to the spinal laminar junction and you undercut the spinal laminar junction, and you can just angulate by releasing the the hole and the retractor, you can manipulate. And also use certain tricks. One of the tricks that is described was to tilt the table itself, whereas what I do is I raise the table and tilt the tube, and you have a better angulation. In an endoscope, the advantage is you're very close to the area where you want, and you tilt the endoscope itself like this, as very elegantly shown yesterday by Professor. The point in a tube is, because the light is at a distance and you have to get that straight line, either you have to rotate the table, or what I like is, I don't like to change the horizontality of the table. I'll get the table up and I tilt the tube, and you are now again operating. If you tilt the table many a times, your orientation can go a bit awry. So the trick is, keep your orientation, anything standard, tilt only one aspect, it will be very good.
And what is the preference for static versus expandable cage?
I tried a few times expandable cage, and there are some very great papers on expandable cage. I'm not really a big fan of expandable cage myself. I would rather use a bigger cage, smaller length, and place it more anterior. Advantage is then you have the screw system to angulate. So the degree to which you want, the idea of having expandable cage is only to what extent you can get lordose it at a single level. Whatever may be the force that you use, you don't want subsidence. The more force you are using at a smaller area of the prepared disc, the narrower the cage, the more chance of subsidence. I don't want subsidence to happen. I would rather have a little less lordosis than a ideal looking cage placement and the lordosis immediate in shop, but 6 months down the line you'll have a subsidence.
And would you put screw on the contralateral side first and have some distraction?
Very rarely. Most times what I do is I do a very good disc work. If the disc work doesn't allow for movement, and then I told you yesterday I use certain tricks, like using a trial itself to break the ALL. I try all that. If that doesn't work, I do the other side too. But again, it depends on cases like this. In a case like this, where there is a fusion, and I'm not very sure to what degree the fusion is going to affect the movement, I am a little conservative in trying to break the anterior osteophyte. Most times there is a movement. If I find there is no movement with a very good disc work ipsilaterally, I'm willing to accept the fact that I'm going to aid further ossification by placing bone graft, may not even place a cage, do bilateral facetectomy, and say, yes, this is optimal for this patient.
Thank you so much.
Thank you.
Yeah, thank you very much, sir. So now we will have the OT-3 first case, which is intradural tumor, to be done by Professor Park.
Good morning, respected faculty. Coming to OT-3 first case, patient is 54-year-old female who is a known case of hypothyroidism. Her complaints are complaints of low backache for 1 year, aggravated since last 2 months, radiating to bilateral lower limbs, more symptomatic on left side greater than right side. Coming to clinical examination, her sensory examination is normal, and coming to motor examination, tone and bulk are normal, and her power is 5/5 in all the joints in lower limbs except for left ankle and EHL. Reflexes. There is hyporeflexia noted in left side knee ankle joint and right ankle joint, and her left plantar is mute. Is that T1 weighted imaging which shows well-defined iso-intense lesion noted at the level of L2 vertebra, which is intradural and extramedullary. This T1 contrast imaging which shows homogeneous enhancement imaging wise, we are suspecting it as L2 intradural extramedullary lesion, likely schwannoma. I would like to invite Professor Park to explain regarding the management.
Good morning, everyone. I'm very excited because this live surgery is one of the first bipolar intradural extramedullary tumor removal. So I believe I have experience for that, and I believe my technique for bipolar. Firstly, I would like to perform the left side L2 laminotomy and upper and low level ligament problem removal, and the contralateral sublaminar drillings and widening of spinal canal, just like a ULBT. And wait this. Okay. After my presentation of tumor removal, I will explain the case. Okay. Because this is unlikely tumor or microscope surgery. This is a water-based surgery. It means water. We have intradural operative. In the operative field, we have a press. Usually around 5 or 4 millimeter Hg. So outside of outside of we have a press. So on the microscope surgery, when you open the duotomy, sometimes the root base is gushy out because outside the press is 0. Inside the dural press is 5 to 15 millimeter Hg. That's why CSF and root base have eruption. But we have water-based surgery, so outside the dura, we already have a press. So eruption of root there is decreased. Small amount of eruption you can see. So that is one of advantage for the water-based surgery. And the other one, if you have a duotomy, fluid separate the arachnoid membrane and the dura. So we can preserve the arachnoid membrane more easily during duotomy. This is my video for dura no need for it. Okay. This is intradural schwannoma, and also 4-5 degenerative spondylolisthesis with cranial stenosis. So with the one-stage surgery, I remove the tumor and decompression and semi-fixation. This is the basics for bipolar endoscopic surgery with the water pressure. After laminotomy, with the preservation of midline structure, including interspinous ligament, and I am doing duotomy. And with the preservation of arachnoid membrane, we can make a duotomy and then find the mass and extract the mass outside the dura, from inside the dura. This is a mass. And this is your pathology findings for schwannoma. This is the findings. And the other one, even the point, with the hemoclave, I try to close the dura. Under the dura, I put the gel foams. And as you can see, hemoclave is MRI compatible and with the aspect of CTs. This is post-operative MRIs, including UABD below levels and semi-linear screw fixation. I like to have semi-linear fixations with a flexible load for grade 1 degenerative recesses. This is post-operative CTs. So this is we have to worry about. We are opening the dura. So everybody are worried about ICP, but because the pressure operating period is spreading to intracranial. So everybody worry about that. I'm also worried about that, but we know very well, intracranial pressure is 5 to 15 millimeter Hg, 7 to 21 H2O, CmH2O. So if you maintain the press, your cervical press under the 15 millimeter Hg, your ventricle, you don't worry about the increased ICP. So this is your real check over CP. If you maintain your outflow, the press you can maintain your surgical field under the 3 or 4 CmH2O. So that's why you can open your dura. I hope you understand my talk. Yeah, so important thing is please maintain the outflow. That is the most important. You can see the bulge out arachnoid membrane. It means intracranial pressure more higher than your operating field. So that's why arachnoid membrane is bulging. This is your real videos. Having duotomy, and I like to dissect the dura with preservation of arachnoid membrane, because the water separates dura from the arachnoid membrane, so we can easily preserve the arachnoid membrane, and looking for the tumor, and finding the tumor proximal margin and distal margins. We don't need the tenting of dura, and then dissect arachnoid membrane to take out mass from inside of dura to the outside. Take out. I'm taking out to the outside of dura. That is arachnoid membrane. And because the bipolar is, we can use endoscopic retractor, so we can hold in the tissues and dissection, with the dam nest, we can separate the normal nerves from the dura. Yeah, holding and separating, holding and separating. So finally, with the preservation of a whole root, I am detaching, separating the tumor from the sheath of root. Yeah, and I control the bleedings. We have a special for tips, pinpoint of radio frequency. With this tips instrument, we can control intradural bleeding from the brain. This is a coagulation mode. Okay, next step is how to close the dura. Firstly, put the gel foam under the dura. Yeah, this is a mess. This is very, very sleepy. To remove it, you need a tooth pituitary forceps. Very sleepy. Today, mess is very big, so I have to separate the mess, several pieces. I believe using the vascular clip, vascular is a very good idea. That's it from me. Really, bipolar surgery, suturing a dura is really impossible. Insert a needle into the epidural space, and suturing it is a really very hard job. Because we have a gel foam under the dura, so we can prevent the impingement of the root web from the vascular clips. And after applying vascular clips, and then I put the tacosil or pressing over the suture site, and then complete my surgeries. It is all. Okay, so what's we can handle. We don't need to include the ICP after the opening of dura because if you maintain the good outflow, this is a very good important slide. If your outflow is blocked, right side, look at right side, the pressure of your cervical pivot is increased very, very highly. It makes problem in the intracranial problem, sometimes pulmonary embolism and other things. But if you maintain your outflow good, you're just like curve. If your curve is overflow, your pressure is only here. But your curve is closed, the pressure is the same level like this. So please, during your operation, please remember opening the outflow. That is the most important things. The other is same techniques for the tubular or microscopic surgery. So I hope this surgery must be wonderful and successful. I believe it. Show me, please. My MRI.
Yeah, any questions? Yeah.
Sorry, Dr. Park, just I want a comment from you because in literature I reported many cases of intracranial hemorrhages after UBE.
Sorry, speak more loudly.
In literature, I reported some cases of intracerebral hemorrhage after UBE for tumors. So do you prevent them only with the output, only regulating the output flow, or what do you think?
Yeah, the problem which is occurred in intracranially is because of outflow problem. But because other doctors use semi-tubular systems, it is very easily closed, and sometimes it is pulled out. So very easily the create passage increased over the 15 millimeter HG. So sometimes if my outflow is not good today, I will make another outflow. I will put a tube, okay? And making continuous outflow, I will continue my surgery. If my outflow is very bad, I will convert my surgery to the open.
I'm sorry, just to understand the problem of intracranial hemorrhage, because I'm not able to understand the mechanism, pathophysiological mechanism of intracranial hemorrhage. Since when we perform tumorectomy by laminectomy, open surgery, microsurgical technique, we completely suck CSF from intradural compartment, and we lower intracranial pressure during old-fashioned open tumorectomy. So which is the mechanism that facilitate intracranial hemorrhage during deliquoration in endoscopic surgery? Which is the pathophysiological mechanism? This is my question.
Sorry, let me know your question. What is the mechanism for intracranial hemorrhage
associated with endoscopic approach?
Sorry, actually in South Korea never reported intracranial hemorrhage, but I have heard about that story in the China at my presentation in Shanghai. Unipolar surgeons which have experience for tumor removal, they have some intracranial problem. So at that time, I believe that the problem was your outflow problem because they use some semi-rigid tubular systems.
I see. Thank you.
Oh, thank you. I have a question. That is it able to use CUSA for intra-decompression, like this kind of big tumor?
Yeah, if we need. Actually, I want to only schwannoma. It is the early stage of surgery, so meningioma or other huge-sided mass, having more experience, I want to do that. But CUSA is just like very easy to fly it. The shapes and the lengths is a very good device for the bipolar. Do you see? So if I need for the CUSA, I will try to use CUSA, but I never use CUSA my surgery. Yes.
And you said that this kind of when you take this kind of big tumor, like you cut it off, like piece by piece.
Because skin is small, so today my size is very big. It is impossible to take out. So I have to take out outside dura and dissect the one piece. Okay, when I remove the epidural space to the outside skin, I have to cut several pieces and take it out.
Okay, thank you.
About putting intradural gel form.
Yes.
Are you worried that it may cause delayed arachnoiditis?
Because we are neurosurgeon, for the brain surgery, if we have a subdural hematoma, many times we put the gel form, subdural space. That does not make problem. So I believe putting the gel form subdural area, okay, maybe it does not make problem. And finally, I try to take out the proofs, take it out.
But even those cases when sometimes we re-explore, there is thick fibrosis that we find in the cases where gel form is placed.
Sorry, I don't have a long-term long-term experience for that. Yeah. Okay, thank you so much.
So, second case presentation. Meanwhile, what is the status of the OR? Can somebody tell me? Just
Coming to OT-3 second case, patient is a 27-year-old male, resident of Ghaziabad, OT technician by profession. His chief complaints are complaints of low backache since last 1.5 years, more symptomatic on right side, complaint of limb weakness since last 6 months, and recent onset urinary retention. There is history of heavy weight lifting. Coming to clinical examination, sensory-wise, there is 40% sensory loss of pain, temperature, crude touch in right L5-S1 dermatomes, and no focal sensory loss on the left lower limb. Coming to motor examination, his bulk is normal, tone is normal, and power in right side knee flexion is 4 minus by 5, ankle dorsiflexion is 4 minus by 5, ankle plantar flexion is 4 minus by 5, and right EHL is 3 by 5. And coming to left side, it is 4 plus by 5 in knee flexion, ankle dorsiflexion, ankle plantar flexion, and EHL. Coming to reflexes, there is hyporeflexia noted in bilateral ankles and plantars are flexor. Straight leg rise test में right side there is 30 degrees and left side 50 degrees. A dynamic X-ray LS spine. There is no listhesis. Coming to MRI LS spine, at the level of L4, L5, there is bilateral disc bulge with disc desiccation with lumbar canal stenosis. Note. L5S1 level में there is bilateral disc bulge with disc desiccation with severe lumbar canal stenosis. And CT spine grossly appears normal at both L4, L5 and L5S1 levels. Diagnosis L4, L5, L5S1 disc bulge with canal stenosis. To discuss operative approach, I would invite Dr. Park.
So, hello. Yeah, as you can see, we have two level L5 and L5S1 hernia disc with combined with spinal canal stenosis. So my surgery two level ULBD. For two level ULBD, we need only 3 skin incision because for one level we can use the working port and endoscope port, and for the lower level we can use the endoscope port as a working port, and we need another endoscopy port. And always bipolar surgery, left side standing is very easy because of direction of the radius. So left side laminotomy and ULBD and retraction of root, both sides retraction, and make sure for the safety of and decompression of bilateral traversing root L5 and L5S1. So I believe it is a simple case. So I don't know why it is. So I want to show you. And so, some difference. I want to talk about the difference between just the UABD and removal of hernia disc. There is some difference. Because for the removal of hernia disc, we have to retract the second, third, or traversing root. So we put the retractor. I like to use the endoscopic retractor. So to put the endoscopic retractor, you have to make the laminotomy more widely. If your laminotomy is small, you cannot put the endoscopic retractor into the epidural space. So making just like a funnel shape, you have to make a laminotomy outside wide, inside is smaller, just like a funnel shapes. So just like a funnel shape, you can put the endoscopic retractor more easily when the contralateral side also. That is an important point for the laminotomy to the removal of hernia disc. Okay, thank you so much. Hello, I will talk about basics, and ordinarily I have been in the uniform and scope surgery, and 2016 I incorporated the bipolar endoscopic surgeries. So, uh, 2000, I have a transplant. I have presentation for the transplant approach and the epidural access and the removal of herniated disc. Also have interest in the interlaminar approach in early 2000. I learned it from the CT-guided interlaminar approach and developed it fluoroscopic guided interlaminar approach in the early 2000s. This is a brief history for unipolar and bipolars, and this terminologies you know very well. From neurology, endoscope is a start. And we know very well about the transcambine 2075-3. Cambine triangle is very, very useful for the endoscopic endoscopic approach into the disc space, in the epidural space. There are two types, inside out and outside the unipolar techniques. And you know very well, this is the standard. And this is a history for bipolar endoscopic surgery. Actually, bipolar technique is not arrived from South Korea. Some South Korea doctors have visited and watched the report and visited AAIIMS, and they make groups, and they start early 2000. And from the 2016, it become popular. I'm also organized over all the unilateral bipolar endoscopic surgeries. About 2 years ago, I was the president of the World UVE. Histories, other things. I will talk about microscope. As you know, it is an air-based surgery, but unipolar has the same housing. So endoscope and instrument has the same channels. So but bipolar, there is a two skin incisions. So endoscope and instrument is separated. So it gave many advantage and freedoms for the surgeries. This is the same concepts. And this is a comparison between unipolar and bipolar, especially to the upper lumbar level and the posterior hypertrophy or spiral process is deviated. Sometimes it's just stocking and very difficult to move. But this is very handy, very easily move because it is very slim. So it is also very good method for the interlaminar approach. But bipolar also have some advantage. This is a very, very important concept. Always your instrument is in front of endoscope in unipolar, but bipolar is different. So right is blocked by the bone. You have to drill out this bone. Your right from the endoscope reaches here. So superficial drilling, always superficial drilling for the bipolar is very, very important. So the amount of bone drilling compared to unipolar, bipolar is more large. So this is a very important concept. You can see only front of the endoscope. You can only front of the endoscope. You cannot see behind the endoscope. If you are table instrument back here, you can hurt. You can miss the table instrument. It means that you can hurt the cord what you are here. But unipolar always is in front of the endoscope. You cannot miss. You cannot miss the endoscope. Always your teeth in front of the endoscope. Actually, I don't like to have unipolar because of radiation. From young age to now, I was exposed to radiation a lot because of this insertion needles. Under the same guidance, you have to insert needles. But now, bipolar is just like a microscope surgery. We don't need we can have a lead free decompression. This is the surgical flows. Yesterday, I already talked about that. So making 2 channels and putting the endoscopes. So with the water pressure, we can make a working space. And because there are always movement of fluid, so we can keep surgical period clean. I mean, bloody tinged fluid is unipolar toward the endoscope because they have only one skin incision. But bipolar, bloody fluid is a different way. I mean, here is blood is moved back toward the endoscope, so when they are bleeding, unipolar fluid is much more bleeding. But if they are bleeding, bipolar is wash out away from the endoscope. So the surgical period is more better in bipolar. This is a concept. Okay. Just like a new endoscopic surgery is moved to the spine, and we can make a create space with a hydrostatic press. Just before intraventricular bleedings and other things, the doctors maybe use the press machine, but I strongly recommend please use a hydrostatic pressure. And some doctors to make a high press here, they use a blood press cuff. So I recommend don't use a blood cuff press or press machine. Only if you use a hydrostatic pressure alone and try to make good outflow, that is the best way. That you can prevent the post-operative problem. This is the same way. And even though we did if we insert this one, the press is increased because outflow is wrong. So when the press is increased, bleeding is decreased. So for the bleeding control, you can control the intraoperative force. And there's no attachment between muscles and bone. There are only pen layer. This is my talk again. If you maintain outflow, please maintain outflow to prevent accident. And this is So this is my algorithm. So I like to have for stenosis, I like to have bipolar. And for the hernia disc, I like to transperineal PELD. Actually, I had 3 times transperineal PELD about 10 years ago. And now I enjoy snow skiing and golf, everything I can do because I had 3 times the transperineal PELD. So, and for the interbody fusion, I believe bipolar is more superior compared to the unipolars. This is a video which is showing, because we have a suction hose, so we can maintain a surgical period clearly, continuous. So sometimes I continue my trainings for over the 5 minutes. So with a single put, I can complete the training sometimes. Okay, and this is why skin incision for walking port is so much important. And I like to have use the blunt dissection and memorize the location of interlaminar space and the cranial area. If your distance is too close, there is a fighting between hand and hand. So please separate more than 2 cms. And if you use I like to use a tubular system instead of semi-tubular systems. And dilation of walking port working port, especially fascia block outflow. So you have to separate the fascia to maintain good outflow. And this is a pre-endoscopic staging. And when you insert, so triangulation, you have to always make over the lamina, try to make a triangulation. Some doctors have a discussion with me, they made triangulation in the muscle area. Muscle area is it's very difficult to find the tip of instrument. So with the contralateral approach, we can decompress both route, axial route and the traversing route with the contralateral laminotomy. And sometimes we can use 30 degree. For the axial route, we can use 30 degree or zero degree. It depends on surgeon's choice. And with the retraction, we can remove it. Retraction of root, nerve, and then take out, just like a microscope surgery. This is also same concepts. And I like to have, if we have a contralateral sublaminar approach with the endoscope, we can preserve facet joint very effectively. So, especially for the upper lumbar level, having contralateral approach is very effective and useful. So I like to use tubula, and this is a comparison between unipolar and bipolars. And talk about learning curves. Learning curve, bipolar is more short, more flat compared to unipolars, and easy to learn. And for instrument, bipolar instrument is short and strong, just like a microscope surgery. So the maintenance of P is very, very cheap compared to unipolars. This is a bipolar short. And this is a comparison. There are unipolar is slim and long and very expensive and very easily breakable. And this is a large working channel for the interlaminar approach. It is an intermediate status, and this is bipolar. Okay. It's me. I had a transforaminal PLD. I know how much it is painful. Impinged pain due to disc is really, really painful. So I have 3 times PLD, and I enjoy golf nowadays. So I don't believe I have someone who has spine surgery. I don't have a spine surgery. And this is important talk. You are unipolar, blood is toward the endoscope, so it is bloody. Do you understand? And here, if there are bleeding, it is away from outside, away from the endoscope, so that your field is more clear when there is some bleedings. This is just showing this one. And the advantage for the bipolar, there is a well-developed radio frequency systems. And unipolar interval fusion, still difficult. But if you learn bipolar, if you have some stage, overstage, everything becomes same difficulty. I believe it is a very important graph. Unipolar is always for new technique. Unipolar is still difficult, but bipolar is not different. And a big advantage for interbody fusion, we can put the endoscope inside the disc, so we can make a fusion better, very, very clearly. That is only one advantage of interbody fusion using bipolar compared to tubeless systems. And I like to put the olive cage. I like to put the removal of facet joint and if you make two cell aneurysm here, you can put oblique, put cage, and lay down here. So you can put olive cage. So for a single level interbody fusions, I think TLIP also comparable with the olive. This is my surgery for two level olive cage. You know, done with my friend, Sachin. Okay, this is also, yeah. Okay. If you want, I will show you this video, but if you don't want, I will stop. What can I do?
No, you can continue, no problem. Meanwhile, the OTR is getting ready, so you can continue. How much, like 5 minutes, 10 minutes? Yeah, sure, continue, no problem.
This is my video. This is my video for transcambing approach and putting olive cage. So I have a facet joint dissection, the lateral part of facet. And my friend, this is a tube of SAP. Removal of tube SAP, because you don't need UABD, only exchange of Camden triangle is my goal for this surgery. So removal of tube of SAP. This is here. This is upper part of pedicle. To exposure and extend the Camden triangle. This is the upper part of pedicle. And you can expose the annulus here. And you can drill out the inferior part of IAP only. Inferior part of IAP only. You can expose lateral marginal dura here. You can expose the lateral marginal dura. You don't need for the spinal canal. You don't need to touch the spinal canal. Only while the SAP removal and drilling of the inferior part of IAP, you can make wider Camden triangle here. So from lateral marginal dura to the lateral disc level, you can make a 2 cm annulotomy. I like to have annulotomy from lateral to the medial, and under the endoscope, I am removing end of cartilaginous end plate. And I am putting olive cage. We can see the safety of dura. It is a big advantage. Of endoscopic surgery. Unipolar, you have to put your cage under the CM guidance, the blind technique. But if you have bipolar, you can see the extend root and traversing root. And also you can retract the root, dura and the extend root also. And you can introduce the cage into the disc space under the view of endoscopic surgery. It is a big advantage for the bipolar surgeries. So I'm putting the olive cage like this. This is the CM views. And then first oblique insertion like this. And then lay down the ipsilateral area, lay down, and make a parallels. This is the widest 18 millimeter HG. And the length is 50 millimeter HG. This is the post-operative MRI, and the footprint of cage, 2-level cage, footprint, 3, 4, and 4, 5. This is a single incision. With this single incision, I put the 2-level only cage and screw fixation. And sometimes I can have a UABD together. This is a method for the transcambing approach. If you don't need for the UABD, I strongly recommend this method. And this is the same case for 2-level olive cage insertions. You can just here. And I wanna show you another video, which when you need the UABD, you have to use a different method. Actually, I have another video for including UAV, but next time I will show because I use too much time, your time. Thank you for giving your important time to me. Thank you very much, everyone.
Thank you very much, sir. Very nice presentation. Yeah, there is one question.
Good morning, sir. Yes, yes.
Good morning, sir.
Yes.
Yeah. How do you approach the foraminal and the extraforaminal disc to UB?
Yes, yes. Actually, for the foraminal approach, if you have my presentation combined with spinal canal stenosis and the foraminal compression, I like to have contralateral after UABD, and through the contralateral approach, I like to decompress the contralateral side of foramen. But if my patient has only foraminal problem, I like to have a wheelchair, paraspinal approach, from midline to the posterior and posterior laterals, and have palpating transverse processor and the lateral orthopedic passage joint, and the external finding and decompression, paraspinal approach. That is, yeah, very not difficult, easy. Yeah.
Thank you, sir.
Thank you very much, sir. Yeah.
Just a question. When you perform olive endoscopic procedures, where do you put the root? Laterally or medially to your endoscope?
Because this is not only tulip, and I put olive cage in the prone position, and after you remove passage joint, and suppose your angle is about 2 cm angulotomy, and put the big size, olive size. Olive size means the wide is 18 millimeter HG, length is 50 milli. So with the tulip, with the posterior transpyramidal approach, I can put olive cage. So for a single level, because you know very well, olive has a lateral position, and change the position for screw fixation is not easy. But if you have a transpyramidal put cage, olive cage, you don't need for that, changing position or other things. Also, we can have a direct root decompression.
Sir, in UB you are using a lot of fluids. Do you have any experience about hypothermia in the patient?
Hypothermia?
Yeah. Certain mechanisms to avoid it.
I have heard about that. In the early stage in South Korea, for a long time, 3 hours, 4 hours, it is exposed to water. So the patient has some stages of hypothermia. Because for 1 hour, we have to use 5,000 cc for 1 level. So rather fluid needed.
Yeah, Revan.
Sir, while doing T-lift through UB, do you do contralateral fasciectomy every time, or?
Yeah, that's a good question. So for serial need, we can, tubular system, I don't know about that, but we can make a contralateral IAP breaking, only breaking for the posterior need. It is possible, but if your segment is flexible, you don't need it for that. But preoperative MRI or CT, you can see the passage joint. Passage joint hypertrophy, nearly fused or locked. You have to plan for the contralateral IAP breaking. But usually I don't break.
Okay. And sir, one
Thank you. Yeah.
One more.
Yeah, please go ahead.
Sir, normally in listhesis, in degenerative listhesis, at least there will be fibrosis surrounding the exiting nerve root. So, if you are not doing contralateral fasciectomy, how to take care of those fibrosis?
Sorry, speak more loudly. I can. Yeah.
Sir, fibrosis surrounding the exiting nerve roots.
Yeah.
How to take care of those?
How to take care of the fibrosis surrounding the nerve roots?
So bipolar is, I told you, is a two-handed surgery. understand? So fiber tissues, holding fiber tissue and dissect, holding, dissect, it is possible. That's why tumor removal is possible. So you can make some adhesion lysis or some release of soft tissues from the nerves. And the water dissection also important concept. Because the always there is movement of fluid, so it is a hydro dissect and the elevation of inflammatory agent, inflammations.
Thank you very much, Professor. Very nice discussion. I think now again we are going to watch you today.
Thank you.
Yeah. So after this, we'll go through the wards. We have the faculty today who are, going to take care of the each ward and will moderate. So Dr. Umesh Gadpal is here, Dr. Yogesh is here, then I see Dr. Vijay Parihar, Dr. Kawaljit, Dr. Shashwat, and Dr. Sukhdeep is here, Dr. G.D. Sattarthi sir is here. So we have the expert faculty which will again take care of the each OR and keep guiding you. Dr. Rakesh is here. Dr. Siddharth Sahu, please come forward, 2 days you have to take care of on OR, please. So, what is the status? Can you take us to OR? OR 1. OR 1.
I'm here.
Yeah, we are with you.
Yeah. What? Audio? Yes. Hello. I hope you can see me. Now we begin surgery. It's approximately T3 L3. I will do approach from one side and we check vertebra what we need. I hope low instrumented vertebra.
Professor Patkar? Yeah. We'll come back to Professor Kolezer in a minute. So, can we take the OT-2? Dr. Patkar sir, we are with you.
Yeah, good morning everyone. Chinmay? Do you want Chinmay only? No. Yeah. I think Chinmay is speaking.
Really?
Yeah.
Call me Chinmay.
Oh, sorry, Dr. Raj. I hope you take it as a pride.
Yeah,
so. Dr. Patkar is just will be in a moment. We have positioned this patient in the extension. We have put a bolster below the shoulder back. Can you please focus here? There's a bolster below the shoulder back, and the head is in complete extension. We have put a for traction. We have put this pins and strap the head so that it doesn't move during the surgery. Okay. So it is completely fixed in extension, and this is based on the X-ray. Can you please show that? And the head is in complete extension. So you can see the X-ray, which is we want the CNCT in the reduced position where we can fix it, and that is perfectly reduced now. It is a camera zoom in, please. So it is completely
can you
fixed in extension.
adjust the angle? Yeah. Okay. Yeah, looks good.
Can you please show that? Okay.
Yeah. No, it's okay. It's okay. We can see.
So the CNCT is completely reduced here. The other thing we want is that the alignment of the occipiting line. So it's more or less it's okay.
somehow the C1 arch is not exactly perfectly aligned, but so intraoperatively we will be, while putting the drill in C2, we will try to manipulate with our assistant Dr. Ishan will be there to move the head and then keep his alignment before we drill into the C2 and then go to C1. So that is our plan. We are just beginning to do our incisions. Dr. Patkar already had marked it, but because Ishan was painting, it is gone. So it is basically just below the mandible, one finger breadth below the mandible. And it starts from the anterior border of the sternocleidomastoid. So this is roughly the sternomastoid here. And one finger breadth below. So it starts from here. And the incision will curve slightly towards the midline. This is basically to expose the digastric tendon, and we actually detach it from the hyoid bone so that we get an axis above. We'll have to retract it below. That's the reason this upcurving is there. And this is our incision for the exposure.
Can you show the incision properly? We could not see it.
इधर दिखाओ, नहीं दिख रहा उनको. Now can you see it?
Yeah, perfect.
So this is the incision starting from the anterior border of the sternomastoid and curving just in the midline.
Perfect. Can you show the incision properly? We could not see it. You want to see the MRI? Can you glide it? Can you take us to the MRI once?
हाँ, MRI को दिखाना.
Yeah, perfect.
Zoom.
No.
That is CT or X-ray. CT,
So there is a question. Your incision, does it cross the midline or only one?
So just at the midline. It doesn't cross it. Just towards the midline, it just curves upwards.
Perfect.
And we are also taking the iliac graft.
Okay.
For taking the bone graft.
Show us the MRI once.
MRI, please.
So there is a question. Your incision, does it cross the midline or?
Is it visible?
Just at the midline.
Yeah.
Doesn't cross it, just towards the midline.
Lighting conditions are not very great.
And we are also taking the iliac graft.
ये थोड़ा ऊपर हो सकता है स्क्रीन के.
Okay.
For taking the bone graft.
Show us the MRI once.
The MRI is visible.
Zoom in.
Zoom कर दो.
Zoom on T2.
तो कैमरा थोड़ा पास में लाओ.
Know what you want.
और तो
You have to ask you. Okay, he wanted to see a cord pinching. Anything else? You are happy now? Yeah.
Is it visible?
Yeah, it's visible.
Yeah.
Thank you. Can you take to OT4?
Zoom in. Zoom कर दो. तो कैमरा थोड़ा पास में लाओ.
Know what you want.
और तो
You have to ask you. Okay, he wanted to see a cord pinching. Anything else? You are happy now? Yeah.
Is it visible?
Yeah, it's visible.
Yeah.
Thank you. Can you take to OT4?
एक मिनट रुको. Can I help you? Can I help you?
Yes. Hello.
You did that ether video?
OT4, please.
Local.
Somebody has to detach this.
OT4.
Help you. Where shall I help? Live?
Yeah, Professor Deshpande is aware with you.
Live? Okay. And you have to put all of that.
Professor Raja Kumar, we are with you.
Hello. Can you hear me?
Yeah, perfectly.
So, good morning once again. We are trying to organize the OT. We have just got things to a shape, and I'll start with the marking, step-by-step approach. So people who know already might find it boring, but people who are right into the minimal access initially, they can watch what I do and see if it benefits them. It's a very straightforward step-by-step approach, like I showed during the cadaveric section. And the same process, if it is followed on a regular basis,
OT-2, Dr. Patkar sir.
becomes a way of habit. So
Hello.
give me 5 minutes, and I think I'll be with you guys.
Yeah, perfect. We'll come back to in 5 minutes.
Hello.
Can you take to
Hello.
Just I wanted to know, the head has to be straight completely in neutral position, or it is slightly turned while we are taking the incision?
We have turned a bit because our exposure is from this side. This is just for the exposure part, but when we are planning to put a screw, then we will have it exactly neutral and then in alignment, perfect lateral and complete extension.
Is there any indication for taking from the left side also, or most of the time from right side?
This is just for the exposure part. I think you have to wait for Dr. Patkar to be here to answer that question. So I will get that answer.
Yes, sure.
Perfect lateral and complete extension.
Is there any indication for taking from the left side also, or most of the time from right side?
Here, left hand island. So I will get that answer.
So while Dr. Patkar is coming, can we go?
So when by the time Dr. Patkar comes, I'll get back online.
Yeah, sure.
Right?
Sure.
Okay. Thank you.
Let's go to
OT1.
OT1.
Yes, OT1 you are connected, sir.
Left hand island.
So while Dr. Patkar is coming, can we go?
So when by the time Dr. Patkar comes, I'll get back online.
Yeah, sure.
Right?
Sure.
Okay. Thank you.
Let's go to
OT1.
OT1.
Yes, OT1 you are connected, sir.
So you're connected.
Yeah.
Yes, Professor.
I'm here.
Also, yes, you are connected.
Look here, please.
So I want to know what are you doing?
I'm doing passive approach, and I'm going to check level on that part of the spine. I'm waiting for all, and after this we're doing C-arm control.
Correct.
Company वाला कहाँ है?
So as you see, all the cases are just getting ready. They are initial stages. So if anyone has any question or some comments or anything, they can just let us know. We can communicate with.
Caller mic to Professor Patkar, please.
Yes, sir, OT2 you are connected.
He is
No.
not available right now.
Caller mic to Professor Patkar.
Enjoying his coffee.
Take us to OT2.
Yes, sir, OT2 you are connected.
Yeah,
sir.
connect that caller mic to Professor Patkar.
Is there anything placed under the neck, below the neck, or it's free? Is there anything placed under the neck, below the neck, or it's free?
We shift to OT4.
Sir,
Also-
क्यों नहीं कर रहे?
ठीक है तो डॉक्टर पाटकर को तो लगा
सर किधर कर रहे हैं?
माइक तो लगा सकते हो. So I want to tell everybody that the streaming is going on. Audio is only one OT continuously. That is OT3, Dr. Art's OT. So at least his audio can be heard continuously if you are interested. Rest of the OTs will be without audio unless.
If you can wait for
the main OT.
couple of minutes.
So in OT2, Ramesh, good morning, sir.
Yeah, hello.
I have a basic doubt regarding the GW traction what we have put, no, sir. I think it's there in the flexion position. It's behind the tragus line. You could have put in the anterior to the tragus line. That could have been given a good extension. So in OT2,
Okay, is that so?
Ramesh, good morning, sir.
Yeah, hello.
I have a basic doubt.
Yeah.
What question?
Yeah, you're right, but it's I think just for. I will let Dr. Patkar come. I can he will answer better.
Question is very relevant.
It's very relevant, yeah.
Traction is put in the flexion behind the tragus lines when we have passageal dislocation, because that is the best way to reduce any kind of dislocation. And usually when we just want extension, it should be put anterior to the tragus line. So if we can just show where the traction then the traction is put in the flexion behind the tragus lines when we have passageal
देखो बैठ जाएगा बराबर से. Hello, good morning, good afternoon.
Good morning, Dr. Patkar.
Yes, sir. Any questions?
Many. So, starting from the position to the incision and to the reduction on X-ray, all three things you can show.
So position he has shown you that the position is with extension. I keep a bolster under the shoulders and the head is fixed in extension to the table. And I put the Gardner tongs before starting. The Gardner tongs were manipulation during surgery.
Do you put any weight on the tongs?
So position he has shown you that the position is with extension. I keep a bolster under the shoulders. And the head is fixed in extension. I don't think, I always feel that the Gardner tongs, if you see properly, where I fixed them in the line of the spine. If you will see the, when you see the proper X-ray skull with the Gardner wells, it is, can somebody take a C-arm and show them that ideally the Gardner well tongs should be in the line of the spine. I always feel that the Gardner well tongs, if you see properly, where I fixed... No, we'll have to do a lateral X-ray before. So the Gardner well tongs, I feel the purpose of the Gardner well tongs is just to see that the rotation is corrected. When I'm passing the screws, the mandible midline is in line with the suprasternal notch and it is held in that position when I want to pass the screws. You get the point I'm making? So that is the reason of the Gardner well tongs. The reduction will come more by the position and opening the joints. Now this is not a fixed AED, but in fixed AEDs, you have to work on the soft tissues between the anterior arch of the atlas and odontine process. And when you remove the panels, the soft tissues, cut the longer scalar muscles, then you will get reduction.
So you put some weight on the...
No weights. You have to work on the soft tissues between the anterior arch.
So we can see on the X-ray there is good reduction.
There is good reduction. So in this position also, if we are able to pass the screws, our job is done.
And here we can also see the lower line of the mandible is above the C2-3 joint.
Correct. So that was the prerequisite for doing the case. That is the prerequisite which is available in more than 90% in my experience. That 90% of the patients, except the very kind of, there is some kind of platybasia, in which case the whole spine is, kind of impinging with a big, there's an angle, very almost acute angle developing between the skull base and the spine. And that is those are the kind of cases which are very difficult to do from the submandibular approach.
And Dr. Patkar, can you explain the incision also?
The incision passes exactly 1 finger depth below the angle of the mandible.
Have the camera focused on the incision?
Yeah, can somebody focus the camera on the mandible? Give me artery forceps system, one artery forceps or some instrument. From the submandibular approach. Can you see this? This is the midline. You can see the thyroid cartilage, the midline.
So the head is kept neutral or it turns
right 10 degrees tilted on the other side.
Okay.
And then during surgery, sometimes they are tilted more. And this is the angle of the mandible here, and the incision, this is the anterior border sternocleidomastoid. The incision is starting from the anterior border sternocleidomastoid and turning upwards and medially. This is because sometimes the muscles are so tight that you disconnect the digastric from the corner of the hyoid. Right. But as time is passing, I have stopped doing that. But today, for the sake of showing anatomy, I am going to do the dissection and show the submandibular gland, the digastric tendon, etc., etc.
So this you said is 2 centimeters below the...
Yeah, about 1 to 2 centimeters below the angle of the mandible. This is the angle of the mandible.
Right.
Can you see the artery forceps?
Yes.
This is the angle of the mandible, I can feel it. This is the mandible. And this is 1.5 to 2 centimeters below it turning up. Because the marginal mandibular nerve which supplies the angle of the mouth can sometimes get trapped in the incision.
And you always go from the right side?
Always, because I am a right-handed surgeon, so I stand on the right side of the patient. But I have done many cases from left side. For example, sometimes there is a previous kind of injury or scar, or so many times I have operated from the left side also. That's not a problem. The anatomy remains the same whether you operate from right or left.
And you always go from the right side?
Unlike cervical, the subaxial spine, where the position of the recurrent laryngeal nerve decides whether you want to go from the right or you want to go from the left.
Correct.
So many times I have operated from the left. Okay, let's get the iodine. The anatomy remains the same whether you operate from right or left. Uska 2 piece kato. Scissor low.
Unlike cervical
Record low.
subaxial spine, where
So we'll just join you in 5 minutes. We can
Yeah, sure.
quickly shift to
Mic kick.
44. Correct.
Let's get the iodine. उसका 2 पीस काटो. Scissor लो. Record लो.
So we'll just join you in 5 minutes. We can
Yeah, sure.
quickly shift to
Mic kick.
44.
No, okay. I can adjust afterwards, don't worry. So,
Dr. Deshpande, we are with you.
we are in the process of getting some AP X-rays and lateral X-rays because this patient is quite obese and we could feel only 2 of the spinous processes. So once the setup is ready, I will come back to you. You can go to other OT, no problem.
Okay. The X-ray appears rotated. It's
Yeah, that's why we are trying to organize it a bit.
okay. Understood.
In that, no?
So we can go to OT-3 and see.
No, that was recurrent so कुछ नहीं कोई anatomy का.
And Dr. Patkar, we are back with you.
You want to do or I should do? No, you can do it. मेरे को कोई दिक्कत नहीं है फिर. वो तो कर दो फिर. After the exposure, I'll take over. Artery force.
42 you are connected, sir.
Come. Take the knife.
And Dr. Patkar, we are back with you.
Suction cautery लगा दो. See, it is very important in this case.
OT1, Dr. Kaleswar.
Completely preserved.
Yes, sir.
Because it can
41 you are connected, sir.
Here. After the exposure, I'll take over. Artery force. Come. Take the knife. Suction cautery लगा दो. See, it is very important in this case.
OT1, Dr. Kaleswar.
Completely preserved.
Yes, sir.
Because it can
41 you are connected, sir.
Here.
Dr. Kaleswar.
Yes, I'm here.
Yes. So you can see the pedicles
We
very
have
nicely.
checked the level, and my O is T5. T5, yeah. We should go a little up.
Yes, OT-2 you are connected, sir.
Dr. Patkar, we are all waiting for you to start the incision.
Very important, that this is the cautery tip. Can you see the cautery tip? Only 2 millimeters left exposed.
Right.
Because when you are working high up, you don't want any collateral damage.
Dr. Patkar.
Because if the cautery is, not covered completely, you can touch the make a opening in the mucosa. There is a carotid artery on one side because you are working down, going upwards. So the cautery tip, only few millimeters should be exposed. When you are working high up,
Correct.
you don't want any collateral damage. Because if the cautery is, not covered completely, you can touch the make a opening in the mucosa. Then we have to take the microscope.
On one side because
So let's take the microscope.
going upwards. So the cautery tip, only few millimeters.
Get the microscope so we can show on the microscope. इधर डालना है? नहीं ये तो चालू कर दो. Microscope आएगा. The 15 number blade, sister 15 number blade and action with forceps. Get the microscope so we can show on the microscope. ये किधर कनेक्ट करना है? माइक्रोस्कोप आएगा. So 15 number blade, sister 15 number blade and action with forceps. ये किधर कनेक्ट करना है? ये क्या है? इधर से. आ जाएगा ट्यूब. चलो लगा दो. ये क्या है? इधर से. चलो यू फोकस ऑन दिस नाउ. कम ऑन. आ जाएगा ट्यूब. चलो लगा दो. So 15 number blade. 15 number blade. And Adson tooth forceps. Come on. Put Adson tooth forceps.
कैमरा फोकस करना operative field पे.
हाँ, चलो Adson tooth forceps. So we are starting from the midline to the anterior border sternocleidomastoid. 15 number blade.
You have to sit there.
And Adson tooth forceps. Come on. Put Adson tooth forceps.
कैमरा फोकस करना operative field पे.
Okay, one more Adson tooth forceps to me. Cautery set करो 30-30 पे अगर वैली लैब है तो tooth forceps sister to me take the cautery. Sternocleidomastoid. Okay, yeah, जो कुछ है वो ले लो. ठीक है.
कैमरा कर रहा है ना वो हो ही नहीं पा रहा. कैमरा मैन.
You don't have a cutting. One more Adson tooth forceps to me.
Sir, we are unable to see.
30-30 पे अगर वैली लैब है तो tooth forceps. Can you see?
No, sir.
The camera is not. Where is the camera?
Cameraman, please focus.
Camera.
Or you can take the microscope, sir, because we are not able to see.
Sir, we are able to see. Microscope, rather, I'll have to show because I will not be able to assist you on the microscope. So microscope, now. The camera is not. Use the microscope. Come on.
Cameraman, please focus.
Camera.
Or you can take the microscope,
आगे आने दो.
because we are not able to see.
Light को पीछे करो. Microscope rather, I'll have to show because I will not be able to assist you on the microscope. So microscope, now. Yeah. Lights on, please. Use the microscope. Come on. Light on. आगे आने दो. Light को पीछे करो.
Shift to microscope view.
Yeah. Lights on, please. Which is focus? This one, sir. This one is focus? Yes. I use it like I know.
Shift to microscope view.
This is zoom out. Up is coming out of zoom or going out of zoom? Yeah. Okay.
Can the table go down a bit?
Yeah, take the table down a little bit. One more Adson tooth, sister. This is zoom out. One more Adson tooth. Up is yeah. Going out of zoom. Yeah. Give me the cautery. Cautery. Monopolar. Yeah. Okay. Can you see now?
Yes, sir. Yes, sir. Yes.
Hello.
Yes, sir. Yes.
So we have taken the incision and we are cutting the skin and the platysma muscle. This is the platysma muscle.
Right.
Cautery. Monopolar. Okay, can you see now?
Yes, sir. Yes, sir. Yes.
Hello.
Yes, sir.
Sister, I will require a stitch now after this. थोड़ा सा sister कम करो इसको, बहुत ही कम छोटा हो गया, थोड़ा निकालो. And the platysma muscle. This is the platysma muscle.
Right.
Pardon? ठीक है. Not.
Height थोड़ा बढ़ सकता है.
Sister, I will require a stitch now after this. थोड़ा सा sister कम करो इसको, बहुत ही कम छोटा. कर दिया क्या? हाँ, निकालो. Thank you. पॉटरी हो नहीं रहा, some problem. ठीक है.
Height थोड़ा बढ़ सकता है.
कर दिया क्या? हाँ. Thank you. All right. There's some error signal in that. वो बैठ नहीं रहा. Some problem. चलो ठीक है. Let us see. वो बैठ नहीं रहा. दूसरा क्वार्टर मंगाओ भैया. No, not happening, sister. चलो ठीक है. Let us see. हो रहा है क्या? Error है उसमें. दूसरा क्वार्टर. Yeah, the problem is in the cable. No, not happening, sister. Oh, switch का problem है. हो रहा है क्या?
So we'll quickly come back to you.
Yeah, there's a problem. The cautery will get it going, then we'll call you.
Then please call us. We shift to OT3, Dr. Park.
का problem है.
Dr. Park, we are there with you.
Can you hear me?
Yes.
Yeah.
So we'll quickly come back to you.
Yeah, there's a problem. The cautery will get it going, then we'll call you.
Then please call us. We shift to OT3, Dr. Park. Dr. Park, we are there with you.
Can you hear me?
Yes.
I can hear you. I can hear you.
Right.
Now everything is prepared, including level markings. I'm going to the school to wash my hand. So see you.
Focus the camera on Dr. Park's. What is he showing? Yes, Dr. Park.
Hello everyone. Hello, can you see?
Yes,
can you see and can you hear me?
Yes.
I am very excited to have a live surgery. This wonderful institute, AIIMS. So now today I will do my best, and I have a plan. Definitely I have a plan. How can I do? And how can
And those days when I was with Ramani had this penchant that first do anterior release and then...
Dr. Patkar.
Yes, sir.
We are there with you.
No, I'm not yet got the cautery going.
Thank you.
So he was asking me what is this craniovertebral surgery seen in Pune. So I said craniovertebral surgery and scoliosis surgery are surgery for poor surgeons. The canal stenosis decompression is for corporate surgeons like my friend Raja Kumar. See, his name is also Raja Kumar. Because they deal with the rich people. Craniovertebral anomaly, the patients are usually coming from some poor village, with the deformed neck, torticollis, or scoliosis also for that matter. Especially worse the scoliosis, more poor the patient. That is my theory. Because those which are early get picked up and they start going from doctor to doctor. When you get a very deformed hunchback, it is invariably a poor farmer's child from somewhere, in remote village. And then he doesn't have money for anything, even implants you have to organize.
Correct.
So, but we are, who are we? We are surgeons, We like to live for nothing and need a reason to die for something, So we want to do more and more complex cases without any monetary incentive. But then as you grow older, now I've finished all my tenure with medical college and all. So my work is restricted to people who are paying money.
Go back to OT number 4. 44, you are connected, sir. Yes. Thank you. Can you hear me? Yes. Can you see this? Yes, sir.
More and more complex cases without any monetary incentive. But then as you grow older, now I've finished all my tenure with medical college and all. So my work is restricted to people who are paying money.
Go back to OT number 4. 44, you are connected, sir. Yes. Thank you. Can you hear me? Yes. Can you see this? Yes, sir. Yes.
For people who are not familiar with this tube, it's called an expanding tube. I want you to see here, the inside diameter is 22 mm.
Right.
Correct?
Right.
Now, this is unexpanded, and I'll expand this, okay? And it becomes double, approximately 4.5.
Okay.
Approximately. So when I want a 2-level or 3-level, I mark this is a very obese patient. I mark this at, can you see this?
Yes.
4 centimeter.
Okay.
So idea is I should land on the facet.
So 4 centimeters from the midline.
From the midline.
And this
the midline is very difficult to make, and this is
cranial
approximation.
Cranial is 9 o'clock.
Cranial, caudal, medial, lateral.
Okay.
I'm standing on the left side of the patient.
Okay.
And there you have this 4 centimeter, I have marked 2 centimeter above, 2 centimeter below. So I'm going to insert here, make an incision, little less first, and I can expand it whenever I want. And I land on the platysma. Hold it up. Injection?
Yes, sir.
Can you see?
Yes.
So I've cut the platysma, and after cutting the platysma, the submandibular gland is peeping at me. Can you see the submandibular gland here?
Yes.
Give me a mosquito forceps, sister. Give me a stitches of barbouche linen or something. I cut the platysma. Seriously, could be there.
Yes, sir.
This is the spot.
Yes.
This is the spot.
This is the coagulate करो काटो, coagulate करो.
ठीक है? Not bad.
Scissors. Switch किसके बाद से? No, I will do it. You don't worry. Just wait. और लगा दो बर्फ में बड़ा मन चाहिए छोटा.
Give me the local sister, please.
Coagulate करो काटो, coagulate करो.
Not bad.
चलो आओ. Switch किसके बाद से? No, I will do it. You don't worry. काट दो. Just wait. और लगा दो बर्फ में बड़ा मन चाहिए छोटा.
Just put subcutaneous.
Local sister, please.
It's all done.
ऊपर मत करो ऊपर. हाँ बस.
We're starting, ma'am.
काट दिया.
Yep.
काट दो. नहीं अभी नहीं. Give me the monopolar.
You have made this initial approximately
Yeah, mosquito लेके जाओ.
2.5 centimeter. You have an abdominal pad, you have like abdominal pad? Yeah, that's
तो स्टेज देना.
what it can be.
स्टेज.
OT4 को म्यूट कर देना.
Give me the monopolar. काटो.
Approximately
Yeah, mosquito लेके जाओ.
2.5 centimeter. You have an abdominal pad, you have
ये कॉटरी दगा दे रहा है यार कॉटरी.
काम नहीं कर रहा है.
स्टेज.
OT4 को म्यूट कर देना.
आराम से.
काटो. नहीं तो मोनोपोल लगेगा अपने यार. We can't work like this. सिस्टर मेरे को फाइन एक्शन देना या आर्ट्रोग्रिप देना हाथ में मेरे. गिव मी अ फाइन एक्शन और आर्ट्रोग्रिप. हाँ दे रहेगा. We can't work like this.
So what are we trying to do right now?
You're asking me?
Yes, doctor.
We are at the lower pole of the mandibular gland and the cautery has stopped working. So they are trying to organize the third cautery now. So काटो इसको. Till then we will organize the bipolar. काटो. काटो please.
So what are we trying to do right now?
You're asking me?
Yes, doctor.
We are at the lower pole of the mandibular gland and the cautery has stopped working. So they are trying to organize the third cautery now. So काटो इसको. Till then we will organize. तो stitch ready करो sister. काटो. Ready है stitch. चलो इसको कट करो. काटो please. Sister, keep this ready. And so I want a stitch ready. कॉटरी का मेरे को मोनोपोलर है क्या? चलेगा? Sister, keep this ready. And so I want a stitch ready. तो stitch देना sister. मोनोपोलर है क्या? चलेगा? इसको मस्किटो लगा खींच लो इधर. छोटा करो बस. उधर खींच लो. उधर फिक्स करो. स्टिच वापस दो. तो स्टिच देना सिस्टर. स्टिच दो वापस. इसको मस्किटो लगा खींच लो इधर. छोटा करो बस. उधर खींच लो. उधर फिक्स करो. स्टिच वापस दो. स्टिच दो वापस. अरे हो गया वो. अरे मेरा चश्मा लगा दो यार. चारू get my spectacle there. बस. अरे मेरा चश्मा लगा दो यार. चारू या get my spectacle there. Mosquito. Mosquito. So, mosquito. For the sake of demonstration, will reflect the submandibular gland, and the structure underneath is immediately the diagnostic tendon.
Okay.
Chalo, give me the cautery, please. Hold this flap. For the sake of demonstration, will reflect the submandibular gland, and the structure underneath is immediately the diagnostic tendon.
Okay.
Sister, मेरे हाथ में atro grip देना, sister. You got an atro grip forceps? Hold this flap. Atro grip. If you got an atro grip, it will be nice for me, you know. This is tooth forceps. I don't want a tooth forceps. Mosquito, please. Sister, मेरे हाथ में atro grip देना, sister. You got an atro grip forceps? Atro grip. If you got an atro grip, it will be nice for me, you know. Milaga, sister, this is tooth forceps. I don't want a tooth forceps. Give me a stitch, sister. So I'm taking a stitch through the connective tissue over the submandibular gland, and that would hit the submandibular gland out of my view. All this is now, unless now I don't do this, today I'm doing it just to show you the anatomy. Come on, take this. So I'm taking a stitch through the connective tissue of the submandibular gland. Mosquito, please. It hits the submandibular gland out of my view. All this is now, unless now I don't do this, today I'm doing it just to show you the anatomy. Very good. See now, the digestive tendon will come into view immediately. Can you see this?
Yes, we can.
Sister, give me scissor, please. Yeah, give me monopolar. Mosquito, please. One of the two. Monopolar, come kar do, sister.
So this is the posterior belly of the digastric.
The posterior belly of the digastric tendon. Okay, very good. See now, the digastric tendon. Can you see this? Beautifully. And here is the corner of the hyoid bone. Mosquito. Please. Yeah, give me monopolar. So, this is just to show you anatomy, you know.
So this is the posterior belly of the digastric.
The posterior belly of the digastric tendon. Can you see this? Beautifully.
Yes.
And cautery system. No, mosquito. So, this is just to show you anatomy, you know. Keep the monopolar minimum, huh? Mosquito.
So do you retract the digastric or you cut it, sir?
If the situation is tight, I'll disconnect it from the higher bone. But most of the time it is not required.
And if you disconnect it, you resuture it back? You just...
I resuture it, but even if sometimes when I'm not done, nothing happens.
So do you retract the digastric or you cut it, sir?
If the situation is tight, I'll disconnect it from the higher bone.
Okay.
It was dissected because you don't know what structure is there.
And if you disconnect it, you resuture it back? Or you just...
I resuture it, but even if sometimes when I'm not done, nothing happens.
The hypoglossal will be...
It will be under the digastric. When I mobilize the digastric, I'll see the hypoglossal. I don't want to go there.
Right.
Like the recurrent laryngeal nerve. If you don't search for it, it does not create trouble.
Right.
If you demonstrate where it is, then you come in trouble. Sister, mala atrogrip I need an atrogrip basis.
The hypoglossal will be...
No, give it to me later. So then I put my finger and I feel the carotid. I don't want to go there.
Right.
Like the recurrent laryngeal nerve. If you don't search for it, it does not. So here I can feel the carotid. Can you see the pulsation also? Then you come in trouble. Sister, mala atrogrip I need an atrogrip.
Not really, sir, but we can...
See, I will ask Dodamani to confirm it. Dodamani? So then I put
no, but we believe this is...
the carotid.
We believe you, sir.
You believe me? No, you should not believe me. There should be evidence to believe me. Give me scissor, sister. Can you see the pulsation also? So this is the plane I was searching for. See, I will ask Dodamani to confirm it. Dodamani, you are getting the point? Now I've got the plane. See, when I put my finger down, I'm feeling the spine. Put your finger down here. Give me scissor, sister. Tighten it.
The vertical part of the incision, vertical limb, is it required to be extended or you just kept it as a backup?
There is no need to extend the incision now.
Okay.
I didn't get your question. Can you repeat your question?
There were two limbs which were drawn on the skin, sir. One was the transverse and one was the vertical.
No, there is only one.
Incision, vertical limb.
Sternocleidomastoid, that is sternocleidomastoid, anterior border is sternocleidomastoid.
Okay.
To decide the posterior extent of my incision.
Okay.
That was the
I didn't get your
sternocleidomastoid.
question.
Can you repeat your question?
There were two limbs
Can you feel the spine?
which were drawn on the skin.
Okay.
Sir. One was
Now, if you are technically correct, we will be somewhere on the C2-3 disc or on the body of the C2. No? Now, get the right angle retractor system. Give me mosquito, please. Decide the posterior extent of my incision. No, मैंने जो लाया ना.
Understood, understood.
Okay. Can you feel the spine? Okay. Now, if you are technically correct, we will be somewhere on the C2.
43 are connected. Dr. Patkar will just join you in 5 minutes.
Yes,
Dr. Park.
No, मैंने जो लाया ना.
43 are connected. Dr. Patkar will just join you in 5 minutes.
Yes, Dr. Park.
Caesar.
Dr. Park.
Something. What to, yeah.
Yes, Dr. Park.
I can hear you.
Okay. So please, can you tell us what you're doing?
Yes, I am putting after the completing triangulation on the L2 lamina, I am putting the trocar. Okay. So can you just write a small bar? Okay. For the good outflow, I made a skin incision, bigger skin incision. Usually 1.5 cm is optimal. I made a small skin incision about 2 cm. This is some vessel. I don't want to sacrifice vessel. I'm going to go about bipolar quarter, please. Yeah.
Yes, Dr. Patkar.
So we have reached the spine. Now we are going to confirm where we are on the spine. Okay. Pottery come karo bhaiya. Pottery come karo.
Make it 10.
What?
Can you center the image?
I don't want to sacrifice vessel. I'm going to go about bipolar quarter, please.
Yes.
Can you see now?
Yes.
So I'm on the spine now. I'm going to take confirmatory X-ray. And if I'm correct, I'm on the body of C2. You know. Give me cautery come किया? कितना पे?
15.
Oh, very good.
Can you center the image?
और कम करो. Can you see now?
Yes.
So sister, give me a QR. Give me a QR, sister. I'm on the body. QR. Give me cautery come किया? Maybe, but I'm not going to spend time because that is why I don't like to dissect from above below too much, you know. Give me QR. QR, sister, give me a QR. Come the right angle, please. Give me a QR, sister. Pardon? Hypoglossal will be above. No. Give me monopolar. Spend time because that is why I don't like to dissect from above below too much, you know. No, don't try to search for it. Then it will not create any trouble for you. QR Manka. One more right angle, please. Pardon? Hypoglossal will be above. No. Give me monopolar. Sister, I want a QR soon. So these are the two longest colar muscles. You are seeing them, you know. No, don't try
Dr.
to search for
Patkar.
it. Yes, sir.
I'm sorry, Visocchi, Massimiliano Visocchi.
Pardon?
Did you detach the tendon of the gastric muscle? We didn't see it. And
No, I did not.
You did not.
I did not. I was telling him that nowadays I don't do that. So this is the longest cola, that's right. So we take the longest cola aside. Give me the cautery, sister.
So you are lateral to the horn of the hyoid bone, right? And
Pardon?
The gastric muscle.
Lateral to the hyoid bone.
Yeah, I'm lateral to the hyoid bone. I was telling him that nowadays I don't do that. So this is the longest. Okay, now I want a QR. I just want to confirm where I am. So I can get, this is looking like a disc to me, or this might be a C2-3 disc. Can you see that?
Horn of the hyoid bone.
QR, please.
Pardon?
Is it a disc, no?
lateral to the hyoid bone.
Yeah, I'm lateral to the hyoid bone. Give me a hammer, please. So this, if I'm right, is, that's all right, I'm not putting the disc. So I can go, this is hammer. Disc to me, this might be a C23 disc. Can you see that? Here, please. Okay, ask for a Siam. Remove that. Remove it. Give me a hammer, please. Remove it. So this, let's do a Siam and check where we are, so then I can proceed with my dissection. I think I'm onto the anterior surface of the C2.
Right.
I just want to confirm that with the Siam image before I do more dissection. Remove that. Let's do a Siam and check where we are, so then I can proceed.
We can
with
shift
my
to
dissection.
OT-4, Dr. Patkar.
I think I'm onto the anterior surface of the C2. I just want to confirm that with the Siam image before I do more dissection.
We can shift to OT-4, Dr. Patkar. Dr. Patkar, we have, Dr. Deshpande, we are with you.
Organize a bit of this initial dissection. And
you are connected, sir.
I'm not connected?
Yes, sir.
Yes, Dr. Deshpande.
So what I'm trying to do is I'm trying to land this quadrant onto the facet joint here.
Right.
Now the facet joint is about 1 centimeter inside and my tubes are short. So I'll have to end up with a little bit of dissection here, but I'll get to it. Once I expose the facet, I can call you guys?
Sure. We'll shift.
This is the one. I need this. So how will I do that? Yeah, this tube is short here. By 1
So there's a
centimeter.
question, Dr. Deshpande.
Yeah?
There's a question from the audience that what made you remove the tubular retractor which you placed?
No. What is the question again, please?
But you had put in a tubular retractor.
The reason is I want to land on the facet.
Right.
If I land on the facet a little medial lateral, I want to make sure that I should be bang on the target, that is the facet. I can adjust it either by moving like this,
right,
or a little angulation.
Okay.
But if you see the tube, the end of the tube is here, but the facet is a little at a depth, about 1 centimeter.
Okay, so we'll reposition.
Dr.
Patkar, we are there with you.
And see the best possible.
Understood.
Okay?
We go
To
back
confirm the position of the needle, which we have tapped into the anterior surface of the C2 body.
Yes.
So once that is confirmed, then we can boldly get on with the work,
So X-ray has still to be done.
Done?
X-ray has not been done with the
No, we are doing it just now. The technician was not there. He has come.
So we quickly shift to OT-3.
So once that is confirmed, then we can get on with the work,
So X-ray has still to be done.
Pardon?
X-ray has not been done with the
No, we are doing it just now. The technician was not there. He has come.
So we quickly shift to OT-3. OT-3. Dr.
Elevate the place. Go higher. Yes.
Yes, we can see that you have a good flow.
Yeah. Outflow is good. But the end score is not clear, just like yesterday.
Yes.
But no, don't touch. Okay. Yeah, breathe. This is the intraradial space. Now I'm starting the drills of intraradial space. We know very well. Here you go. Here is a 2-3 intraradial space. You have to remove
we have to remove L2 lamina.
Right.
Okay,
So will you remove the whole lamina or just the undersurface of the lamina?
Can you see the lamina over here?
Yes.
And I am drilling. This is L2 lamina. Okay.
Right.
So my goal is having left side heavy laminotomy to expose the dura, and I would like to preserve the midline structure.
Okay.
So for the stability. So this is L2 lamina, okay. Because ligament flavum is a wonderful protection barrier to the injury. So you always try to use your ligament flavum as a protection barrier for the never injury from the wrist.
Can you orient us to what is cradle and caudal?
Okay. 6 o'clock, 9 o'clock is head, okay? 12 o'clock is the midline, 12 o'clock is the midline, and 3 o'clock is the coda, 3 o'clock is the leg,
right?
And 6 o'clock is the operation site, ipsilateral. So we are near the upper intralaminar space. Here is a upper 1-2 intralaminar space here, 2-3, 2-3. 1, 2, okay. And here we are looking for the midline, okay? Here, 2, 3, 1, 2, 1. Okay, you can see the epidural pad here, coagulation.
Yes.
Coagulation. This is the head of butterfly, okay? When you find the first epidural pad, here is the midline cutting. So we made the technique for the butterfly ligament flavum removal. I call here head of butterfly coagulation. Okay, good. So you have to I'm doing contralateral sublaminar drillings to expose epidural space. So because epidural space is open,
Dr. Patkar?
Yes, sir. See the C-arm. We are on the anterior border, we are past the K-wire.
Right.
And the K-wire is on the anterior border of the C2 at the lower end. Just above the C2-3 disc. Can you see it?
We go to OT-2.
Can you see it?
We are seeing the microscope view. Dr. Patkar?
Yes, sir. The X-ray दिखा भैया. We are on the anterior border, we are past the K-wire.
Right.
And the K-wire is on the anterior border of the C2
Right, sir. We can see it. Just above the C2.
मेरे हाथ में section दे भैया.
Can you see it?
ये पकड़ लो ऐसे, ये पकड़ो. This section monopolar दे दो.
We are seeing the...
So this is the opening which we have done in the body of the C2. Now I am going up and I am going to separate on top. And the C1 C2 joint is apparently 1.5 centimeters above. Because I had seen yesterday. So this is the opening which we have done in the monopolar system. Now I am going up. And I'm going to separate.
The longest coli you cut like we do in cervical disc, or you cut it transversely, sir?
No, I only cut the medial half of the longest coli when I reach the level of the joint. Monopolar system. We are in the midline.
So one of the audience has asked a question, would you prefer nasal intubation?
Does not make a difference to me. Because I am much above, no?
Right.
So this is the longest school, I must say. You can see the longest school. Give me the bipolar sister.
So one of the
Yeah, I'll
audience
do
has
it.
asked the question ki, would you prefer nasal intubation?
See, it does not make a difference to me. Okay?
Yes, yes.
Can you see now?
The longest coli on the
This is the longest school on the right side.
Yes.
This was the needle.
Right.
Where I passed.
Right.
As per the yesterday's study on the CT scan, the odontoid begins about 1.5 centimeters. So from year to year, this must be the beginning of the odontoid process, you know.
Right.
And here I will get the anterior atlas.
Right.
As per yesterday's study on the CT scan. Right.
So how later do we dissect out the longest coli?
To expose this, I should be able to see the entire joint, you know.
The entire joint. Right.
So now I am reaching almost the anterior arch of the atlas here. Where is the anterior arch of the atlas? I can feel it with my instrument. I will show you.
So how later do we dissect out the longest
So now you see the opposite longest colar muscle also.
Yes.
So it is always easier to start the dissection on the opposite side. And you will see the joint over here because I am exactly 1.5 to 2 centimeters above. So I will get the joint over here. Sister, give me the monopolar, please. One minute. What is the cautery Dr. Sarat Chandra is using yesterday? Is the same cautery?
No, sir. That was molecular resonance. Sir.
Huh?
That
Vesalius.
Yes, sir.
Vesalius. He was a great anatomist. It was Vesalius who purchased the body of his servant.
No, sir. That was molecular resonance.
वो Vesalius है?
Vesalius.
कौन सा पेड़ है? ये है ना? अच्छा ये किस? अच्छा ये Vesalius है क्या? It was Vesalius who purchased the body of his servant. हो नहीं रहा. It is not happening but. ये Vesalius है? हो नहीं रहा Vesalius. कौन सा पेड़ है? ये है ना? अच्छा ये किस? Yes. Now it is happening. Very good. Amazing, what? Amazing. ये कितने को मिलता है लेकिन ये? 50 lakh. Oh my God. Cost is very less. Yes. Right? Very good kind of cost. Amazing means what? Amazing. पानी डालो थोड़ा. 50 lakh. Oh my God. Cost is very less. Right? Good kind of cost.
So we can start seeing the out. Can you center again, Dr. Patkar? We can see the what we think is the joint now.
You're asking me?
Yes.
Yeah, I'm reaching the joint now.
Can we center it?
Yeah, I'll do that.
So we can start seeing the out.
Okay.
Can you center again, Dr. Patkar?
Sister.
We can see the what we think is the joint now.
You're asking me?
Yes.
Yeah, I'm reaching the joint now.
Can we center it?
Yeah, I'll do that. Under here.
Yes.
Okay. On the facet, superior facet, you know. Yeah, Mirko, I'm very much impressed with this cautery here. Everybody doesn't get to do it, huh? Under here. सिर्फ सीजर देंगे वो जरा ये लिगामेंट इसका पैड वगैरह निकाल देंगे बीच में आ रहा है ये मेरे को I'm very much impressed with this cautery. Yeah, this is a part of the anterior longus ligament with the longus collar. Everybody doesn't get to do it, huh? This will give me a biopsy process. सिर्फ सीजर देंगे वो जरा ये लिगामेंट so give me that bipolar. Go here. Yeah, this is a part of the anterior longus ligament with the longus collar. Sister, give me a biopsy process. Yeah. Not only that, I need to tilt this a little bit. Throw it. Just hold this. I will tilt the microscope now. Yes, sir. Suction. Bipolar giving system. I need to tilt this a little bit. Throw it. Just hold this. I will tilt the microscope now. Yes, sir. Suction. Bipolar giving system. Just 1 minute.
That is the superior surface of the joint?
Of the C2, yeah. Just a second. Give me monopolar system. Just 1 minute.
That is the superior surface of the joint?
Of the C2, yeah. Just a second. Give me monopolar system. Yeah. See, this is the superior facet. Lateral mass of the atlas. Just as any bone that is lateral, superior lateral to the root is the pedicle in the lumbar spine.
Is there any chances of being near the vertebral?
No, the vertebral is still lateral. We studied the CT scan that is why.
Right.
And the vertebral was far away from us. And what we are seeing now, see this, the entire joint surface. Can you see the joint surface?
Yes, very nice.
And this bone on top is the atlas. This is the lateral mass of the atlas. We studied the CT scan that is. Sister, give me the scissor, please, or give me a blade. Far away from us. See now, see this, the entire joint surface. Can you see the joint surface? Give me 15 number knife, sister. And this bone on top is the atlas. This is the lateral mass of the atlas. ठीक है, अभी तो सुबह भी ठीक है. Sister, give me the scissor, please, or give me a blade. So I'm cutting the ALL and the soft tissue on top of the joint surface, you know. Give me 15 number knife, sister. Give me bipolar. ठीक है, अभी तो सुबह भी ठीक है. So I'm cutting the ALL and the soft tissue on top of the joint surface. Give me the biopsy process, sister. Biopsy process. Give me bipolar. Bipolar. Give me the biopsy process, sister. Vedamani, you are appreciating now the joint very well.
How medially do we go, Dr. Patkar?
Pardon?
How much medially do we go?
No, we go right up to the midline and laterally until we expose the whole joint, you know. See, this is a C1 facet.
How medially do we go?
No, when you pass a keep this and pass a screw into the screw will go nowhere else except into the lateral mass of the C1. So let me clear the anterior surface of the C1. See, this is all the lateral anterior surface of the C1. Can you appreciate it?
Once you clear this tissue, yes, now we can.
Can you see now the C1 lateral mass?
Yes, we can.
Except into the lateral mass of the C1. This is the entire. Now I know where the lateral mass of C1 is going in which direction. See, this is the entire square bone of the lateral mass of C1.
Right. Once you clear this tissue, yes, now we can.
Can you see now the C1 lateral mass?
Yes, we can.
This is the entire. Now I know where the lateral mass of C1 is going in which direction. Now, to say that the position is correct, the C1 and C2 must be in the same plane, you know. And the bipolar, yeah. We have to make it straight, you know. Yeah, see this. Yeah. See now I exposed completely. Can you see this is the beginning of the oriented process? Okay? Yeah, you can see now the oriented process. See this. See this. Can you appreciate?
Yes. Can I
Now let me come on this side.
can I ask you a question, Dr. Parker?
Yes, sir.
Yeah. The structure, we appreciate that the bottom of the right spread is the hypoglossal vessel.
Can you appreciate?
Hypoglossal artery. Can I ask you a question or not?
Yes, sir.
That one, right.
Which one? This one? Maybe, but it is far away from me.
Yes.
So I'm not spending time to search where it is coming and where it is going. But it is there, it is far away from me, nothing to worry.
I see. So you don't isolate at all?
No, don't, if you spend time exposing it, there is a chance that you might injure something monocular. But it is far away from me.
And laterally, what about sympathetic one?
What about sympathetic chain? I think that is also along with the carotid artery and far away. No, don't, if you spend time exposing it, there is a chance that you might injure something monocular.
So you didn't detach tendon of the gastric nerve, didn't isolate hypoglossal nerve, just spread laterally?
Just when laterally, didn't spend time searching for it. Previously I used to search for it.
Yeah.
You know, and then I used to sometimes end up in neuropraxia. Nowadays I don't spend time searching for it. I just proceed with my work, you know.
Hypoglossal nerve just spread laterally.
Just when lateral didn't spend time searching for it. Previously I used to search for it. You know, and then I used to sometimes... So I'm cutting a little bit of longer scola now. Nowadays I don't spend time searching for it. I just proceed with my work, you know. So I'm cutting a little bit of longer scola now.
Sir, before putting the screw, please let us know.
Yeah.
We'll come back to you.
Sure. After I finish my dissection, I'll call you.
Right, sir. So we go to Dr. Park.
Yes.
Please. Dr. Park, we are there with you. Sir, before putting the screw, please let us know.
Yeah.
We'll come back to you.
Sure. After I finish my dissection, I'll call you.
Right, sir. So we go to Dr. Park.
Yes.
Please. Dr. Park, we are there with you.
Yes.
Please tell us what you're doing.
Sure. So, I cannot understand your talk. What's going on? Oh, yeah. I'm exposing to a coagulation. Here, coagulation. Power, full power. No fluid. Open, opposite side. Coagulation. Not working. Cutting. Stop.
Why is the view not so clear, Dr. Park?
Coagulation. Yeah. I don't know. Maybe it is a problem of endoscope.
Okay.
This condition of endoscope is the same as yesterday.
Yes.
So it is a problem. And because view is not good, so I am exposing dura like this. Can you see white color here?
Yes.
This is a dura, and 12 o'clock is a contralateral margin of dura. So after exposure of dura, I want to open the durotomy, okay? Punch. So I'm trying, you can see the movement of soft tissue. Movement of soft tissue means outflow is good.
Yes.
So if
If outflow has a problem, we cannot see anything because of bleedings. So, because we can see the movement fluid and we can have visions. It means lately outflow is good. Only I am focusing on is maintaining good outflow. This is a contralateral. Here is a contralateral dura here. And here, I am exposing.
We are now exposing the joint on the opposite side, and we have exposed the joint a little bit on this side. I will show you the joint within 2 minutes.
We'll go back to OT-2. Yes, Dr. Patkar.
So we are now exposing the joint on the opposite side, and we have exposed the joint a little bit on this side. I will show you the joint within 2 minutes. Bipolar the system. You can see the atlas. Can you see the lateral mass of the atlas?
Yes.
Bipolar the system. So that is the entire lateral mass of the atlas. And this is the facet of the C2, you know. You can see the atlas. Can you see the lateral mass more laterally?
Yes.
So that is the entire lateral mass of the atlas. And this is the facet of the C2, you know. So I want to go a little more laterally. Go a little more laterally. Just to give me a dissector, please, or something, some instrument to palpate. Yeah, we drill this. You can do retropharyngeal oriented also. There is no problem. Bipolar. We should not do. I don't think we should do transfer oriented. Just to give me yeah, people are not comfortable because they are not using microscope to expose this, you know. Once you use microscope to expose this, see, within how much time we were already on the joints. We should not do. I don't think we should do transfer. Yeah, because they have not attempted this approach. Not comfortable because they are not using. Once neurosurgeons attempt this approach, they will stop doing. Once you use microscope to expose this, see, within how much time we will सामने हो joints. Why take all that risk? Yeah, because they have not attempted this. इसका right angle ठीक करो यार. Once neurosurgeons attempt this approach, they will stop doing. ये इधर सामने हो Why take all that risk? So now, इसका right angle ठीक करो यार. इधर
कटिंग कितने पे है सिस्टर मोनोपोलर पट्टी कर दीजिए
So now
30 इसका मोनोपोलर कटिंग कितने पे है सिस्टर मोनोपोलर
1 minute. Just to give me some time, you know, before I make my decision what I'm doing. I'm getting lost in the anatomy for some time. This is not a new case, you know. This is an old case where there has been a, see the scar formation, you know. 1 minute. Yeah, I'm still not seeing C1 facet properly. Make my decision what I'm doing. I'm getting lost in the anatomy for some time. This is a biopsy for some new case, you know. This is an old case where there has been a, see the scar formation, you know. Just a छोटा लगा है आपसे Yeah, see, this is the joint. You can see the joint, no? Monopolar system. Just a biopsy for सकते हो. ये बराबर नहीं मानो. Just a छोटा लगा है. Yeah, especially you need to excise this old tissue, yeah.
Yeah, there are a lot of panels, no, because this is a very old injury. This injury is almost 6 months old, you know. So, lot of kind of, you know, fibrous healing has taken place.
Yeah, especially you need to excise this old tissue, yeah.
Yeah, there are a lot of panels, no, because this is a very old injury. This injury is you're appreciating now. Old, you know. See, this is the joint we have exposed. So, lot of kind of, you know, fibrous healing has taken place. Give me that bipolar system. You're appreciating now. See, this is the joint we have exposed. Give me that bipolar. This is the facet. Now, so far we were not on the facet, you know. Now you can see the facet. This is the facet. Now, so far we were not on the facet, you know. Now you can see the facet. Yeah, that is why he's struggling. Give it to me. Yes.
You need to dissect ipsilateral side because you have tendency to go to opposite side.
This is the atlas. Bring it down here. Yeah, that is why he's struggling. Give it to me.
You need to dissect ipsilateral side because you have
Now it is
tendency
well
to go
seen.
to opposite side.
Give me monopolar, sister. Bring it down here.
Yeah.
Suction. Not suction. See, now it is well seen. The facet is here. Give me monopolar, sister.
So this joint is more lateral than we thought it's.
Yeah.
No, ipsilateral you tend to miss.
Yes.
So you tend to go to opposite side. So
Yes,
this is-
parallax.
I'll check. Give it to me. You can hold another suction there, darling. I need one suction here.
So this joint is more
Bipolar
lateral than
too.
we thought it's.
Yeah.
No, ipsilateral you tend to miss.
Yes.
So you tend to go to opposite side. So
Yes,
this is-
ले जाओ उसको suction. I'll check. Give it to me. You can hold another suction there, darling. I need one suction. Cautery कम करो. Bipolar too. 20 करो 20. Give me monopolar, bipolar. इसका bipolar कौन सा black है ना?
Hello, OT-4, you are connected, sir.
Yes.
OT-4.
Yes,
Can you see, please?
Yes, we can see.
Give me monopolar, bipolar. इसका bipolar कौन सा black है ना?
Hello, OT-4, you are connected, sir.
Yes.
OT-4.
Yes,
Can you see, please?
yes, we can see.
This is the facet of.
Can you just
S1.
orient us with the S1 cranial?
So let me explain again. Let me unzoom.
Yes.
So this is the medial side of the patient.
Right.
This is the lateral,
Right.
inferior, superior.
Right.
Now I have some challenge in this particular patient because of the way the table and construct is there. It should be a little bit more like this, but because the holder is there, it's moving. It's okay. But can you see the S1 here?
Right.
This is the L5 S1 facet. Can you see the movement here?
Yes, yes.
Okay? The L4 file will be somewhere here, forget it. This
Right.
is L5 S1. So I want to make a cut here and take out this bit and take out this bit. Then I'll be in the L5 S1 Cambin's area. Okay?
Okay. Can you just point out the pars interarticularis?
Yeah, that's the challenge here. There is some movement here. Can you see it here?
Yes.
So I'm not sure where this, but when I take out, I can show better.
Okay, okay.
Are you clear now?
Yes, yes.
So I can just zoom it. I just made this. And I also want to understand one thing. From here to here is 8 centimeters.
Okay, so deep.
So it is really very obese patient, 8 centimeter from here to here. Okay?
Right.
Give me a monopolar, please. Okay. So give me a chisel. You have a chisel. And you can give me a regular chisel, yeah. Narrow chisel. ये बड़ा है. Narrow. Show me this. Yeah, this is great. And give me a. Can you give me a mallet?
So this first cut is on the.
I'm trying to take out it in a. The first cut should have been like this, but there's a parts defect.
Okay.
I don't want to go there. I'll
Right.
take out in piecemeals like this. So can you see the gap there now?
Yes.
So I'm being very gentle. I don't want to be. In the regular case, I can be harsher.
So this is the inferior articular facet
Yeah.
of L5.
Yeah.
Okay. Pars is already defective, so you have not.
No, give me a disc forceps you have? You have a regular disc forceps, huh? Straight. Yeah, this is good. Keep the bone, keep the bone, keep the bone. The bone should be kept, sister, don't discard it. You have a slightly bigger one than this. You have a slightly bigger than this. Yeah, give that please. Basically, I want this to go. Can you see it now? The whole thing is moving there. Can you see it now? Huh? Be gentle, huh? Don't be in a hurry to finish the case. Leave it. Take out the suction. So can you give me a forceps? Suction to me, sir.
Dr. Patkar?
Yes, sir. We have finished exposing both the joints, subfacetal regions and the atlas. Now we have tilted the head and fixed the head. We want to remove that fixation so that when we are looking, the facet joints are in the same straight line and that the atlantoaxial dislocation has got corrected.
How have you fixed the head, sir?
With a sticking plaster. We have a very famous gadget in Mumbai side. It is called chicken patti. Chicken patti. Chicken patti means sticking. Chikat means sticking.
Okay.
Patti means tape.
So you have fixed the
head in extension and rotation to the opposite side. Let him cut it. In Mumbai side, it is called chicken patti. Chicken patti.
Can you just de-zoom and show us the position, sir, on the?
Yeah.
So you have fixed the
head in extension and rotation to the opposite side.
Okay.
इसको उठाओ ना ऊपर यार वो चिकन पट्टी जो है ना वाइट कलर का दोनों दिखेगा आपको
नहीं we are just microscope
पेशेंट को मत काटो कोई ट्यूब मत काटो चलो क्या करोगे काट दिया ऊपर यार वो चिकन पट्टी जो है ना वाइट कलर का दोनों द सेम वाइट बॉय नॉट देना व्हेन वी हैव पुट जो बंदा वही थिएटर में रहे मत काटो कोई ट्यूब मत काटो दोनों काट दिया चलो ठीक है अभी लेट्स यस नाउ टर्न द हेड मेक द हेड स्ट्रेट Good tilt. Ready, let's put the retractor. Right angle retractors. Right angle.
You have made the head neutral again.
Yes, we have made it neutral again. Now we are going to go and see what is the situation inside. Chalo. Chalo, ठीक है. Abhi let's, yes. Now turn the head, make the head straight. Good tilt. Ready, let's put the retractor. Right angle retractors. Right angle.
You have made the head neutral again.
Yeah, you can raise this capital. See now hold this. Now you can see the atlas and this facet. They are just over each other. Can you appreciate?
Yes. Can you focus?
I'll just focus now. Yeah, you can raise this capital. See now hold this. Section. Now you can see the atlas and this facet. They are just over each other. Can you appreciate?
Yes. Can you focus?
I'll just focus now. See this. This is lateral mass. This is a facet.
Right.
Okay?
This was the ledge which was seen on the
Right. Correct.
This is the left side.
So we have to fix it little on that side. And we're pushing this in the position. This is the position. So see, I'm reducing the atlantoaxial dislocation with the retractor which is pressing on the lateral mass of the atlas.
Okay.
Can you appreciate?
Yes.
When I remove it, I'll send it to you. Hold this. Pushing this in the position. This is the position. So see, I'm pushing. Is it centered now? Okay. Now appreciate one thing, see. After you release everything, what you can do, you press this. See, they are brought in the same plane.
Yes.
The facet, the lateral mass of the atlas and the superior facet are in the same vertical plane. You can see Sayadri plane. So when I pass the screw, they will be fixed in the same Sayadri plane.
Right.
You get what I'm saying?
Yes. So you push down with your retractor?
That's right, with my retractor.
Yes. You push down on the...
Whichever, the atlas is the one which is usually in the front.
Right.
So you push down and bring it. No, that. See, it is getting dislocated. This is the position. See, now they are both in the same plane and we'll pass the screw like this. That will be the plane of reduction. Now let us see the other joint also.
Push down on the...
Now that we have brought this in neutral, let us study the other joint. What is the situation in the other joint? Doctor. Hold this. This is the position. See, now they are both in the same plane and we'll pass the screw like this. That will be the plane of reduction. Now let us see the other joint also. Now that section we have brought this in neutral, let us study the other joint. What is the situation in the other joint? Doctor. This is. One minute, पूरा अंदर जाना नहीं तो section कौन मेरा सिस्टम देखो. Yes. So now you can see this facet.
Yes.
Okay, this is superior facet, this is inferior facet. I'll pass the screw will go nowhere else but into the lateral mass of C1. And they are in the same plane. Yes.
So first we will put on the equilateral side.
Opposite side. The opposite side is always easier.
Okay.
So from here to here, it is very easy for me to put the screw. I have to first put it and see whether the reduction which I wanted is available or not available. And if the joint is open, I'll curate the joint and take some bone grafts from the iliac crest. Show me my curate system. Now just I'll show you the curates which I brought. It is very easy for me to put the screw. With an array of curates, downward pointing, upward pointing. Can you see them? Can you see?
Yes, we can see.
And where the other curate system? Plus the standard carving, which is downward pointed. So that is used to prepare the joint with an array of curates. So now I can even put the drill, but I prefer to use the scissors. Can you see?
Yes, we can see.
And where the other curate system? And remember, this is not like a regular joint or something with a synovial and all inside. People talk about capsule, but I don't think that the atlantoaxial joint has any restricting capsule. hardly a very flimsy membrane. And even if you just make a little this in the cortex, you violate the cortex, it is going to start fusing. See this? It is gone inside for more than a centimeter, and I pull out, and I'm preparing the cortex on the superior surface. So sister did the other curate which is directed upwards. Just make a little this in the cortex, you violate the cortex, the other one. Up curate, no? Inside for more than a centimeter, and I pull out, and I'm preparing the cortex. So this, I'm making, violating the sister did the other curate which is directed upwards. End plate, you know. And once you violate the end plate, nothing else but bone will start growing from it into the bone graft that I put. And see this. You have to remember that the joints are inclined laterally, they are not straight downwards. They are inclined laterally. You understand? That is why when you pass the screws from behind, you always direct the screws immediately. Right. And therefore, when you curate also, you should remember that your curate should go laterally. You have to remember that the joints are inclined laterally, they are not straight downwards. They are inclined laterally. You understand? That is why when you pass the screws from behind, you always direct the screws immediately. Right. And therefore, when you curate also, you should remember that your curate should go laterally. Well, sister Apollo curate them. So you see how safely you can garden the joints when you are working from behind, because there is no fear. Now I am getting this grating sensation all throughout.
So we'll join you in a minute.
Yes, sure.
We'll shift to OT1.
Yes.
Dr. Kolosov?
Yeah. So you see how safely you can garden the joints when you are working from behind, because there is no fear. Now I am getting this grating sensation all throughout.
So we'll join you in a minute.
Yes, sure.
We'll shift to OT1.
Yes.
Dr. Kolosov?
Yeah.
We are there with you.
Yes.
Tell us what have you done so far?
I'm introducing typical screws on the apex of the concave side.
Okay.
The formation very mobile, in one position, almost straight. And
so we will still go ahead with the pontiff osteotomy?
Maybe a little.
Okay.
A little. Because very mobile. I think 45. Good.
Okay, we shift to OT4.
Can you hear me?
Yes, we can.
So what I have done is I just removed the facet here.
Right.
The facet is removed. You can see part of the facet lamina is still there.
Right.
I removed the, show me that piece of bone I just removed now. Give it to me, keep it here. The big piece of bone, give it here. So you can remove the inferior facet, it was like this.
Right.
I just taken it out. Now I want to identify the superior aspect of the pedicle of S1, which is somewhere here. Give me a hook. I of course widen this whole area. Hook please. So this is the SAP and this is the area of the S1.
Right.
Pedicle, right?
Right.
So up to that I can easily take off. Give me a chisel. Oops, it's angulating down. Just gently shave this off like this.
get as much bone as possible. Okay. Yeah, and give me a drill. All neurosurgeons should learn fine drilling. Give me a hook.
Are you trying to feel for the pedicle?
Yeah, I'm trying to feel for the pedicle. Pedicle is here. Yeah, see, this is the medial aspect and this is the pedicle here. Okay? Drill please. So the idea is to be at the level of the superior auricular facet drilling. Yeah.
OT4 3 OT4 3.
Okay,
sir, we'll just join you. OT4
Which
43,
way
sir.
is the best?
43.
Okay, looking
Yes.
for.
Dr. Park,
Yes, yes.
We are there with you.
Yeah, we make a copias. So we have a big hope. Yeah, we made a turotomy, and I'm looking for the tuner. But it is 30 degree, so it's not easy.
So dural incision you have made.
Yes, yes, already made. And we can see the root thread here. Yes. And looking for the tumor, turotomy, and the root thread is here, double. Making turotomy, and I'm looking for the tumor here. So we can use this retractor, like this, gently retract here, like this. Move to here. We know very well this is okay, because this is okay. I know dissection and okay, and I think that this way reduce the input, reduce the fluid input, reduce the fluid input, please, and give me pad, cotton please, make a cutting. You have to take your circle, okay? Don't touch it. Because it is 30 degree, okay? One more 0 degree. Try it, okay? Try it.
So tumor, have we seen the tumor? Dr. Park?
Yes?
Tumor is visible or not?
But I don't know what to say. Sorry, speak again.
Could you see the tumor?
Yeah, I found tumor. And I will dissect tumor, but this is just 30 degree. Give me 3 minutes, 5 minutes. I will make beautiful and call you again. I'm changing the endoscope. Try it.
So previously you were using 0 degrees.
Yeah. Now the quality of 0 degree is so bad. I change the 30 degree, the vision become good. But
I'm not familiar with the third degree, so I'm changing 0 degree again.
Again 0 degree.
Okay. Fully. I think we can find off. Okay. Okay. Connected. Everything connected. Okay. And input auto. And auto focus. Right balance. Right balance. Put height balance.
You guys screwed up. Yes, sir. So the joint is prepared. We are ready now. Now we are going to pass a QR and just see the trajectory and confirm that we are going in the right direction.
Oh, that's great.
चलो केयर मेरे को really big the system.
I think
Pankaj sir, I had a question for you.
Yes, please.
Sir, how do you know that the joint is adequately prepared? I suppose Seaman on SUI2 is convex and convex joint. So you are doing it with the curate. So what is the end point that you know that you have to stop?
I got curates which are of 1 to 1.5 centimeters in length at right angle.
Sir, how?
And they are not got this kind of curate like this, you know. You see this curate?
Convex and convex.
Serious. But this is not the correct one for this case. I could not get my curates there in the OT, and there was somebody had a case, and now I start having my own instruments. They are hospital instruments, so I have to listen to that you can't take them. This would not have happened 20 years ago, Serious. So I got curates which will go down for about 1.5 centimeters inside. And measure the length of the joint on the CT scan also. It is usually between 1.5 to 2 centimeters, very rarely more than 2 centimeters. So you must be able to go inside for a significant amount of length to curate. See this now? I am getting this grating sound everywhere, Confirm, you can hear it or not? The grating. Hello? So tell them that there is a grating sound, which means that the joint has been prepared, Please, now we have another Carlin's curate which I am putting inside, and you can feel the grating sound. And can you see how the things are moving? In treatment of deformity, you have to create more instability. When you create good instability, then things are better, So now that we have got this, sister, give me the microphone. Grating sound. And can you see how the things are moving?
Usually require assistance for retraction, or there is some assembly for self.
There is assembly, but I have realized over a period of time there is nothing better than an assistant. The reason being that he knows exactly how much pressure, where to relax. And these self-retaining ones, once they are applied, you forget about them and you end up in a lot of muscle damage.
Assistance for retraction, or there is some assembly for self.
Yeah. There is assembly, but a lot of people ask me this question, why are you doing this well? So this, you can see now the entire joint has been prepared. Can you see? This is the middle end of the joint and this is the lateral end of the joint. So you have to take the midpoint of the joint, go 5 to 6 millimeters below and 2 millimeters medial. Is that what I'm saying? Yes. 2 millimeters middle, and your screw should be directed till 10 to 15 degrees laterally. Okay? So now I'm going to make a drill and pass a QR and just confirm that my direction is going to go correctly. So this is the drill. Is that what I'm saying? Yes. Oh, usko baba. ठीक है baba bhai. Take something.
Okay.
So now I'm going to make a drill and pass a QR and just confirm that my direction is going correctly. So this is the drill. Oh, उसको बाबा ये बहुत बड़ा है यार ओके ठीक है चलो so you have to get both are in the same plane. Can you see? Yes. Can you appreciate that the atlas and this axis, they should be in the same plane when you are going to pass your wires, your what is it called QR or your screw, they must be in the same plane. Only then the AD has been corrected. I would prefer if we could take a Siam quickly now, with this in position. Can you take a Siam?
Sir, sometimes the passage is entirely placed in hypertrophy.
Yeah.
In that case, how we make
You can bring the, yesterday I showed that case of visual imagination with the facet overhang. You can bring that overhanging portion. You delete the overhanging portion which is hanging on to the facet of the C2. Just like an osteophyte when you're doing subaxial spine, if it is encroaching on the anterior surface of the disc, you do that. You do that, and you can see then you got adequate space to enter there. Remember, the facet is very big. Within a few millimeters of the anterior aspect of the overhanging is not going to create any trouble for you. If it is encroaching on the anterior surface of the disc, chalo lateral karo. You do that, and you can see then lateral karo, and when you doing the lateral, I will use the microphone to I'll hold the drill. Millimeters of the anterior aspect of the overhanging is not going to create any trouble for you. Chalo lateral karo. Can anybody hear me? Lateral karo, and when you're doing the lateral, I will use the microphone to OT-4. I'll hold the drill. Can anybody hear me?
Dr. Deshpande?
Yeah, can you hear me?
Yes.
So I'm seeing the neural structure here. You see the data there?
Yes.
So what I'm doing is I'm trying to see if I can decompress at till the spinal lamina junction.
So this is the traversing nerve root?
Yeah, that's right. So you see now I can see the decompression up to the near midline.
Right. Good. So we'll just come back to you. We can go to OT-3, Dr. Park.
Can you see the? Yeah, I'm removing tumor. Everybody coagulation, always coagulation. Shrinkage of mass, okay? Firstly, I have to find the T bubble.
Dr. Park, we see a lot of blood on the
coagulation. Sorry, I have to focus here, very important point. I can show you coagulation. You can see here, coagulation, stop.
Yes.
You can see the root right here.
Right.
And also you can see the mass, okay?
Yes.
So I am dissecting and removing. This, you can see here, root red and tumor, pituitary. Okay.
Okay, we'll shift to OT-2. Yes, microscope view. OT-2. आवाज नहीं आ रही है OT-2 से.
You see the Siam image?
Yes.
Can you see that the atlantic axis dislocation is reduced completely?
Yes.
Now you see I'm placing the drill. चलो shoot microscope view. ये image है नहीं. Microscope view दे उनको. दे दिया microscope view?
Yes. Now
you can see I placed the drill as the plan what we did. अब आप Siam करो.
Siam is in PIP. Yes, sir.
Now you see I'm placing the drill. चारों मारे चश्मा काट बनाओ दिशा में
Microscope view.
I can't see with my spectacles on.
Microscope view दो इनको. दे दिया microscope view? Yes, yes, now we can.
एक मिनट देखो ये राइट एंगल का हटा देना बोलूंगा तो
सियाम करो.
हटा दो
सियाम को PIP में
हटा दो अभी शूट करो
चारों मारे चश्मा काट बनाओ.
शूट करो see you can see my drill bit in the subclassical region shoot karo see this is the direction because I am going to go towards the posterior superior end of the lateral mass
PIP को बड़ा कर दो.
अभी शूट करो can you see this can you see the drill bit
No, it's not centered, so that's why.
no I am asking to see the Siam image
Okay, Siam we can see.
can you see on the Siam image
Yes, yes.
very good
Posterior
superior
end of the lateral mass.
अभी डालो see but you remember when you remove the retractor with the dislocation is recurring a little
No,
bit
it's not centered, so that's
see
why.
no I am asking to see the Siam image you understand what I am saying okay so now you keep the retractor in position very good है ना अभी हटो अभी शूट करो एक बार आगे hold it in that position see but you remember but don't move now shoot with the dislocation is recurring a little bit देखो उसको पोजीशन मिला pushing in the C1 है now you keep the retractor in position हाँ बस अभी शूट करो अभी शूट करो एक बार आगे hold it in that position हाँ कितनी गड़बड़ हो रहा है शूट No, this is not acceptable. He is pushing in the C1.
What is the issue, sir?
डाल करो अभी शूट करो शूट करो एक्सटेंड करो कुछ तो भी गड़बड़ हो रहा है हाँ एक्सटेंशन चाहिए दिस इज द पोजीशन दैट वी वांट है नॉट एक्सेप्टेबल नाउ विल यू होल्ड इट इन दिस पोजीशन
What is the issue, sir?
ओके गिव मी द ड्रिल सिस्टम डाल करो अभी शूट करो व्हाट एक्सटेंड करो अभी फिलहाल मत कुछ बोलो फिलहाल ऐसे रहने दो आई विल पुट द ड्रिल एक्सटेंशन चाहिए दिस इज द पोजीशन दैट वी वांट ओके नाउ विल यू होल्ड इट इन दिस पोजीशन ओके गिव मी द ड्रिल सिस्टम व्हाट अभी फिलहाल मत कुछ बोलो फिलहाल ऐसे रहने दो आई विल पुट द ड्रिल अभी शूट लो see it in reduced position. Can you see? The posterior arch of the atlas and the spinal line of C2 are in the same line. Can you appreciate that or no? Okay. So I am removing the drill. अभी शूट लो सिस्टम मेरा टैप दो see it in reduced मेरा टैप Can you see? The posterior
Can you zoom in the Siam image?
C2 are in the same line. Can you appreciate that or no? Okay. So I am removing the drill. सिस्टम मेरा टैप दो मेरा टैप
Microscope view कर दो.
No, on the drill. हाँ हाँ मैं ड्रिल बिट के साथ में पूछ रहा हूँ
Siam image PIP में रखो.
ड्रिल बिट कहाँ है
Sir, on the X-ray image, it seems to have it become irreduced. I mean, less reduced.
The one with the drill bit?
Siam image PIP में रखो. Yes.
Can you extend it? That is, he removed the extension. Now just now see shoot करो. Arya. Shoot करो. Seems to have
it become irreduced.
See now.
Yes, now it is.
Now you hold it in this position, my dear. Suction में मिलेगा.
Yes.
Don't. Can you extend it? That is, he removed the extension. Now see shoot करो. Arya. Okay, now you would hold this position. Will you do that? Okay. See now.
Yes, now it is.
Now you hold it in this position, my dear. Suction में मिलेगा. Don't.
Please don't put pressure on the eyes.
Okay, now you would hold this position. Will you do that? Okay, sister, tap to me. Okay. Where's my screw? क्या करना है यार please? Give me the screw. The screwdriver and the screw. अरे यार the instrument वाला नहीं है ना. चलो. तो डालो. चलो वो.
So when we do the do it posteriorly.
Yeah.
Sometimes to make it reduce, we just put a towel clip between C1 and C2 to keep it reduced.
Correct.
Can we do the same?
We can put a tap.
Yes.
We can put a tap, and the tap can hold it in position. That is possible.
We do the do it
I had shown in the video yesterday. No?
Right. To make it reduce, we just put a towel.
So this is the screwdriver which has got the screw fixed in it. Hold the extension now, darling.
Do the same.
Holding an extension now.
Yes.
I want the tap with the tap. That is possible. I had shown in the video yesterday. Our instrument maybe no tap. So this is the screwdriver which has got the screw fixed in it. Hold the extension now, darling. Holding an extension now. Correct. I want the tap with the tap.
What is the length of the screw?
18 to 20 I put because yesterday I measured. So our instrument maybe no tap. Yeah. एक बार शूट करो भैया. Shoot करो. See, you can see this. It is going in the lateral mass, in the center of the lateral mass it is going. Where it is going? Lateral and downwards. Shoot करो. See, you can see this. So this is going up. I need a bigger drill bit, which she doesn't have. She has only 3.5, she's saying. इसे ज़्यादा drill bit नहीं होता है क्या? Lateral and downwards. नहीं है? She doesn't have, she's saying. So this is going up. I need a bigger drill bit, which she doesn't have. She has only 3.5, she's saying. इसे ज़्यादा drill bit नहीं होता है क्या? This is my tab, you know. नहीं है? सिस्टर को स्क्रू भर के जाना. स्क्रू लोड करो सिस्टर.
शूट करके देख लें.
शूट करो. Okay?
Yes.
The reduction is maintained. The screw is going to the lateral mass. Can you appreciate?
Yes, yes.
And the spinal line of the C2 and the posterior artery are in the same line.
Right.
Okay?
Yes.
Please, Dr. Research, they are asking whether he is happy or he does not agree. Okay?
Yes.
The reduction is maintained. Professor Researches.
Yeah, congratulations.
What is your opinion? Are you happy with it?
I'm so excited to see this beautiful operation. My only question is, which is the length of the screw?
Yeah, yesterday I measured the correct screw for this patient is between 18 to 20 mm.
20.
Are you happy with it? There is screw over. That's all. दूसरे किधर गए?
This beautiful
हाँ, इसको लगाया ना screw.
question is,
Okay, so this is the screw which is locked. The screw is locked in the. Yesterday I measured the correct screw for this patient is between 18 to 20 mm.
20.
अरे पागल है तू. There is screw over. that's all. दूसरे किधर गए? हाँ, इसको लगाया ना screw.
Would a lag screw help? Although obviously length will never be available for lag screw.
Pardon?
Lag screw. So have you tried?
I don't like the lag screw. I like these. Is it going inside that? No, it is not going.
Would a lag screw help? Although obviously length will never be available for lag screw.
Pardon?
Lag screw. So have you tried?
I can't feel it going inside that. Give me that tap of mine, sister. Give me my tap. See, I need a fatter drill bit, which they don't have. They are saying. No, it is not going. I needed a drill bit which is fatter, not this. No. I need a fatter drill bit. I can't feel it going inside that. Give me that tap of mine. This somehow is not there. See, this is going beautifully into the lateral mass without any problem.
Which they don't have. They are
See,
saying.
can you appreciate this?
Yes,
The
yes.
drill bit which is fatter, not this.
This has gone into the lateral mass. And the lateral, see, they both are fixed.
Yes.
The C1 and C2 are fixed. See, they are moving together.
Into the lateral mass without any problem. See. Can you appreciate this?
Yes, yes.
Can you see this?
Yes.
This has gone into the lateral mass. And the lateral, see, they are fixed.
Yes.
Screw their system.
The C1 and C2
You know
are
the
fixed.
screw.
See, they are moving together.
क्या हुआ? फिक्स किया ना? ठीक है. Can you see this?
Yes.
sister. Show me the letter now.
शूट करके देखो.
क्या हुआ? फिक्स किया ना? ठीक है. Siam, shoot.
Can you show at the microscope the
Yes. Can you see the screw has gone across into the lateral mass?
lateral profile
Yes.
of the lateral mass joint?
Yeah. I'll show you. Under the microscope?
Yes.
Show me the section. Okay.
Can you show at the microscope?
See this. This is the lateral profile.
Beautiful. So you are in the middle but closer to the midline.
Correct. And I passed it laterally. I passed the screw laterally. But can you see this now? They are moving in one. There is no separate movement between the atlas and the axis.
Yes.
And can you see the Siam image?
Yes.
That the screw has gone into the atlas, across the atlas. Can you see?
Yes, sir, we can see.
Okay, give me the screwdriver, please. And I passed it laterally. Please give screwdriver the color. But can you see this now? They are moving in one. There is no separate movement between the atlas and the axis.
Yes.
And can you see the Siam image? Yes. So I'll still put the bone grafts inside, you know? Across the atlas. Can you see?
Yes, sir, we can see.
Okay, give me the screwdriver, please. Just give screw. So now remove this. Now on the Siam, you do flexion. Catch the lateral this. Yes. And fluoro chalu karo. Very flex. There is no movement on flexion extension. Can you see that?
Yes, we can.
Extend karo. Flex karo. Can you appreciate that there is no movement between the atlantoaxial joint? Can you appreciate it? Very good. Put it down. Okay. So now I'll put the screw on this side, then I'll put bone graft in the joint, and then we'll cover it.
Yes, we can.
Afterwards. Because we'll do a little deformity correction here, but we can always pack it. There is no problem. There is no movement between the atlantoaxial joint. Can you appreciate it? Very good. Put it down. Okay. Yeah, but we have to put cortical cancellous chips. I don't want to put any big chips.
Thank you, Dr. Patel.
Yes, sir. Did you appreciate the fluoroscopic view that there is no movement?
See it very nicely.
Very good. What about Professor Visochi? Did you see that? Because he is a man with a lot of experience in this case. Professor?
Yeah?
What is your opinion? Is it correct?
Very good. Very good.
Thank you. Right angle, please.
Thank you, Dr. Patel.
Thank you. Right angle.
Thank you.
We shift to 83.
See it very nicely. Very good. What about Professor
Dr. Park?
Did you see that? Because he is a man with a lot of experience in this case. Professor?
Yeah?
What is your opinion? Is it correct?
Very good. Very good.
Thank you. Right angle, please.
Thank you, Dr. Patel.
Thank you. Right angle.
Thank you.
We shift to 83.
RFIF.
Dr. Park?
For me?
Dr. Park?
Yes. Correlation. Yes. Correlation. I can hear you. Correlation.
Yes, how much tumor you have removed?
Shorter cutting. Just before I remove the tumor. So, you can see the root here.
Yes.
And here is the duotomy, okay?
Yes.
And this is the root, which made the tumor, root cyst, which made tumor. So, I am really tumor is removed. So, I don't know. I will explain the surgical anatomy.
Right.
Yeah, I made a duotomy here.
Yes.
And this is the root red.
Yes.
You can see here. And here is this is the dura, and root red is here. You can see root red.
Yes.
After moving the IDM into the extradural area, and I removed it. So this this is root, which made schwannoma here. So this will remain the pituitary. Partially remain the mass pituitary. So this one, you can see here. So
So I wanna cut here. I wanna cut here. Remove here. Okay, move the lateral side. Okay, and then with RF I will cut here. Okay, holding it like this. RF, please. Okay, holding again, okay, like this. It's good, it's good. Quarters, please. Quarters, please. Cutting, 짧게 cutting, please. Cutting. 짧게, shortly. Cutting. Cut. Correlation. Okay, it's good. No. Line. Please keep the line. Okay, we are here. So, double end. Steady, please. You can see durotomy here, double end. Wait a minute. Durotomy here. Wait a minute. I have to find the. Where is the plastic? I'm looking for the plastic. Okay. 줘봐. And please increase the height. Please increase the water height. Press height. Water level increase. Okay.
44 you are connected, sir.
Yes, okay. Yes, Dr. Deshpande. Hello. आवाज नहीं आ रही OT4 से.
Can you hear my voice?
Yes, now I can.
So this is the L4 lamina.
Right.
This is the area of the Campbell's triangle.
Right.
This is the S1 pedicle just below this.
Yes.
So what we are seeing is, I took a little bit of time because I'm a little concerned about, give me a dissector please. Quiet, don't talk. Quiet please. Here in the OT. Can you see the dura here?
Yes.
And there seems to be sort of a structure which appeared to us like possibly like a horizontal nerve root. See, it's coming from here, but I'm not sure. So I'm not going to touch this. I don't have stimulation, so I'll leave it like that.
Right.
Could be, I don't know what this is. There seems to be an initial area where I can find the space, but I'm not sure. I don't want to cut this off. Interesting thing in all this is, the discussion was it is fused, right?
Right.
So I'm going to the disk space here, correct?
Yes.
Okay? And I'm seeing whether the L4 is moving or not. Okay?
Yes.
Sorry, the L5.
L5 over S1.
See the L5?
Yes.
Can you see the L5 moving?
Yes.
Huh?
Yes, we can see.
So that's my concern, because many times we think that it is fused, but it may not have been fused very nicely, except the anterior. Can you see the movement now?
Yes, we can. Dr. Patkar has left.
No, I'm here. They're removing harvesting bone graft.
Okay. Right. Thank you so much.
So did you appreciate the points, technical points?
Yes, sir.
Now, once the joint is fixed on one side,
OT2,
yes.
Dr. Patkar has left.
No, I'm here.
Audio has gone. OT2. Acha, okay.
Now on the other side, we just have to get the screw across the joint.
Correct. Yes, sir.
With bone grafts inside the joint. So if you can see here, show me that implant we have assisted. मेरा implant देखो.
Yes.
Camera को इधर ले जाओ.
Audio has gone. Right.
And they go right up to 12 mm.
Okay.
But the average ones which I put are between 5 to 7. And see this, they are of different shape, unlike what Atul Goyal or Dr. Sarat Chandra used yesterday. And these sit in the center of the joint. First I pack the joint with bone grafts behind and then push this cage. The purpose of the cage is only to maintain the distraction and there is enough space for bone inside, and then I put this plate across. You can see this VSP plate?
Yes, yes.
So one screw goes into the lateral mass and one screw goes into the body of C2. And this plate will sit flush with the facet joint. Sometimes I have to fashion, with a bore, I will fashion the surface that it is a flat surface and the plate fixes into the body of C2 and into the lateral mass of C1. So this is the option if you are not able to pass the these transarticular screws. And the plate design is a VSP design. So you pass the first screw above and then the second screw you pass very close to the edge. The screw goes inside, the width of the screw, it will slide upwards and cause compression at the C1, C2 joint.
Okay.
You get the point I'm making? Yes. With the VSP principle, the first time when I sent it to the journal that neurological research that I'm editing, Denzel had a nice talk with me saying this concept seems to be very nice for treatment of fractures using a VSP plate.
Okay.
This is another plate which has been devised for this area, C1, C2 area. And you can see this, there are places to pass the screws. One screw in the center for the distal fragment of the odontoid, and then two in the body of the C2 and one in the lateral mass each.
Oh, very nice.
So this is also made by Jayon for me. Of course, I have absolutely no financial interest in the manufacturing or in his profits. It's just that we should prepare everything, get it ready for me whenever I want to operate. And then two in the body of the C2.
Thank you, Dr. Bhatt.
Thank you, thank you.
We shift to OT3. Oh, very nice.
So this is also made by Jayon for me. Of course, I have absolutely no financial interest in the manufacturing or in his profits. It's just that he should prepare everything, get it ready for me whenever I want to operate.
Right, Doctor. Thank you, Dr. Bhatt.
Thank you, thank you.
We shift to OT3.
Position. 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 Stop. Be careful. Position. 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 Maybe breathing focus is here. You need a peck. Maybe here. So gel foam and maybe some I don't know, some arterial bleedings here. So correlation. Whether you're here, maybe here is the main bleeding focus. Cutting. We can put gel foam again. Put gel foam in coagulation. Do you have a surgery cell? Coagulation. This is surgery cell. We can pack it here. Arbital or other things.
So Dr. Park, we are with you. Now you're going to close the dura.
Yeah. After bleeding control, we remove the tumor and left turn is closing dura, but there are some arterial bleedings, so I'm controlling the bleedings.
Okay.
After bleeding control, we can close the dura, double N. Maybe here. I hope here is the bleeding focus. I think this is a very good idea. And And cotton head, please. You have other things. This one. Hope we can control here. This one. Okay, and here. Maybe. Double M, please. Double M. Pituitary, please. This is gel form. Surgery cell 말고 뭐야? 본인이 잡는 게 여러 가지. Okay, be careful, be careful. You don't care. This is root. Yeah, over the root. Okay, this is durotomy, okay? Double M, please. Pituitary, please. Pituitary. This is your gel form. Surgery cell. Can you your surgery cell? Give me for surgery cell. Surgery cell is best. Here is no bleeding, okay? But bleeding may be here. It's 6 or 5 o'clock. So I want to try here, okay? And hold it like this. Hold it. Double N, double N. Okay. I hope you can control the bleeding here. Here. Okay. This is okay. And
tell me whenever we are hearing. Yeah, so we are now ready for the other side. We are getting ready to pass the screw on the other side. And like I said, once you have got one screw good, then the other side is pretty simple.
Then
tell me whenever we are hearing. Yeah, so we
are
now ready for the other side. We are getting ready to...
In posterior approach, we put the bone graft first and
yeah, we are going to put the bone. See, today I was reading, see, it is very, when you do demonstration surgery and all, you are actually Hawaii style, you know. So now I am going to put the bone grafts in this joint first.
We will unscrew some threads before putting the bone graft.
Pardon?
We can loosen the screw to put the bone graft. Or
no, we are putting only, we don't want any distraction. We are putting corticocancellous strips. So now I am going to put the bone grafts in this joint first.
So we will unscrew some
चलो भी क्यूरेट ले लो क्यूरेट दो जॉइंट को साफ करो
we can loosen the screw to put the bone graft or
no we are putting only we don't want any distraction क्यूरेट दो सिस्टर ये नहीं हाँ ये दो चलो so we are curating the joint चलो भी क्यूरेट ले लो क्यूरेट दो जॉइंट को साफ करो even the drill, you got a drill with a burr, very fine burr. Let's go fine burr law. So we are curating the joint. Put a fine burr on the drill system. Even the drill, you got a drill with a burr, very fine burr. You got fine burr law. इससे बड़ा लगाओ इससे बड़ा burr लगाओ. Put a fine burr on the drill system. देखा मेरे को हाँ ये चलेगा लगा दो इसको देखा इससे बड़ा लगा देगा इससे बड़ा बर लगा मेरा इसमें मिस्टेक क्यों हो रहा है यार orientation I positioned it correctly, but while going I am making an error. ठीक है बात नहीं you proceed. चलो इधर सिस्टर बदला अगला मेरा इसमें
लगाएगा इधर दिखा दो
orientation है मेरा I positioned it correctly but while going I am making an error अच्छा ठीक है
दिखा
you proceed चलो इधर सिस्टर बदला आगे ला
ना एंगल हैंड पीस पे लगा
दिखा दो
एंगल हैंड पीस पे लगा you can put this in the joint and घुमा it see whether this is going in the joint
दिखा
is it going now घुमा it just keep on don't push it too much inside keep on घुमाएं it
एंगल हैंड पीस पे लगा
are you not breathing
you can put
very
this in
good
the joint and घुमा it
ज़्यादा मत डालो अंदर हाँ
see whether this is going in the joint
very good निकाल दो
is it going
so now see the cartilage is injured and there is bleeding so it is above बढ़ गया sister
are you not
वो
breathing
ले
very good
ज़्यादा मत डालो अंदर हाँ very good निकाल दो so now see the cartilage is injured and there is bleeding so it is above बढ़ गया sister थोड़ा सा tilt में फिक्स हो गया ऐसा लग रहा है मेरे को इधर स्पेस कम है हाँ वो साइड में स्पेस ज़्यादा है जानते पर फिक्स दैट इज मोर देन सफिशिएंट ला इधर ये देखो इसकी जाता हुआ देखो जॉइंट में अंदर डाल दो इसको फुट स्विच पे पहले फुट रखो डोंट प्रेस इट फुट स्विच की तरफ देख लो वो साइड में स्पेस ज़्यादा है एक बार लगा के देखो चल रहा है ना बस बस चलो अंदर जॉइंट में डाल दो ये देखो इसकी जाता हुआ देखो जॉइंट में अंदर डाल दो इसको जॉइंट में जाने दो पहले अंदर फुट स्विच पे पहले फुट रखो डोंट प्रेस इट गया अंदर उसकी तरफ देख लो चालू करो धीरे धीरे एक बार साइड टू साइड चल रहा है ना बस बस चलो अंदर जॉइंट में डाल दो बस जॉइंट में जाने दो पहले अंदर बस 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 बहुत हो गया बहुत हो गया चलो बोन पीसेस भर दो अंदर साइड टू साइड बस 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 बहुत हो गया चलो बोन पीसेस भर दो अंदर बहुत बड़ा है जाओ ना डाल दो फिर ये इंस्ट्रूमेंट लो या बहुत बड़ा है जाओ ना डाल दो ये इंस्ट्रूमेंट लो या इससे लंबा स्क्रू है क्या इससे लंबा स्क्रू है क्या
Hello, OT1 you are connected, sir.
बोन ले लेंगे
Hello, OT1 you are connected, sir.
बोन ले लेंगे क्या बोन पकड़ लेना
connected to the audio in auditorium.
I think definite mobilization. I can just show Nelson Peterson, Panther, or Stotoni, if you want. One more. Give me Christian, please. Thinking, cleaning here, here, sometimes I said, here, yes, indeed. Do you have bearing? How do you?
बोन के सर देना चाहिए एक लूप बना के देना ड्रिल और बोन के
Drill.
नॉर्मल
High speed. Just show.
Okay, sir. OT-2, you are connected, sir.
See now, go for it. Drill with low.
ऑन करना
So you will again sir see in the CM or it's just okay to go ahead with the.
No, उसका डायरेक्शन ऊपर होना मांगता है ऐसा नहीं ऐसा होना
Okay,
मांगता
sir.
समझ गए ना
OT-2, you are connected, sir.
See now, ज़्यादा लेटर नहीं
Hello, Dr. Pathak, sir.
इधर देखते रहो हाँ ठीक है जान दो तो ड्रिल मारो
To go ahead with the.
एक मिनट मेरे को इंस्ट्रूमेंट को तो भी नंबर 4 उसका डायरेक्शन ऊपर होना मांगता है ऐसा नहीं ऐसा होना मांगता है यस समझ गए ना
So sir we need to see again in the CM or it's just.
we will pass the drill for a few millimeters and check in the CM तो ड्रिल मारो एक मिनट मेरे को इंस्ट्रूमेंट को तो भी नंबर 4 अच्छा तो tell me what you want I'll do yes
So sir
चलो ठीक है अब हो गया
again in the CM.
सक्शन में मेरे को सिस्टर we will pass the drill for a few millimeters and check in the CM see this हाँ हाँ okay one minute tell me what you want I'll do चलो ठीक है अब हो गया सक्शन में मेरे को सिस्टर yeah इसको थोड़ा सा so look at keep on looking at the lateral which vessel one minute so I'll get it out for you yeah no it has to keep on looking yes keep on looking at the lateral थोड़ा और डाउनवर्ड टिल्ट करो चलो करो करो फाइन करो so I'll get it out for you एक मिनट रुको हाँ चलो अभी देखो keep on looking yes करो yeah whatever I can see your tip tilt करो चलो करो करो फाइन करो थोड़ा डाउनवर्ड टिल्ट करो and laterally medial to lateral जाओ हाँ करो whatever I can see your tip थोड़ा डाउनवर्ड टिल्ट करो ये होल तो बराबर ले आपने लेकिन and laterally नहीं it is medial to lateral जाओ हाँ no निकालो okay wait a minute देखो अभी ये होल तो बराबर ले आपने लेकिन देखो अभी मंगा तो इस टिश्यू हटा दो मैं कॉटरी से नहीं एक वेसल के ऊपर ओके चलो ठीक है ओके चलो देखो अभी 1 मिनट देखो अभी मंगा तो इस टिश्यू हटा दो मैं कॉटरी से नहीं नहीं बेसल के ऊपर let us see yeah जान दो चलो
Go back to Yes. 41 you are connected, sir.
yes so let us see yeah जान दो
Go back to 41 you are connected, sir.
Before. What's blood pressure?
Blood pressure?
Yeah.
72 mean.
71,
72 mean.
Okay.
Only one muscle.
Okay. Maybe make injection dexamethasone.
Okay.
Maybe 34 milligrams.
How much milligrams?
34 dexamethasone. 34. Maybe 25. Can you give?
Good. That's what they're saying. It should improve.
Should improve.
It should improve. We'll do it after some time.
Can you give me for filling spinal cord dissector. Okay, do you have red, please? No, just red. Give. No, red.
OT-2 आ गया ना?
Would you, I think,
3-rod technique.
Yeah. Okay. Can you cut? Open. Yeah. Cut. Yeah. Good. French bending. Can we water here? Maybe you repeat stimulation. Mm-hmm. Good? Mm-hmm. Uh-huh. Okay.
So this is a desired correction?
Yeah. I'm thinking. Okay. Maybe. Let's cut now. Uh-huh. Open. If you want, I can. Okay.
There's a maximum opening.
Good. Yeah. Okay. Set screw. Rocker. No. Do you have rocker? No. Rocker. It's possible to use. Possible. But we should have a little another. Yeah. Yeah, hold this. No. It's good. Yeah. Yeah. Rod holder. Yeah.
Any tightening. Any tightening.
Another one. Two. Try to make the rotation. No, you did it. Direct the rotation. I don't like it.
So this technique is called?
hold this. Hold this. Mm-hmm. Mm-hmm. Hold this. Hold. Mm-hmm. Mm-hmm. Hold. Hold. Mm-hmm. Mm-hmm. Awesome. Yeah. Take this and yeah. Can you push? No, push. Just like.
Okay.
Yeah. Mm-hmm. Yeah, good. Yeah. Okay. Sec, please. Mm-hmm. Okay, an explanation. Good. Screwdriver. Yeah. And distractor. Mm-hmm. Hold. Here. Fix. Mm-hmm. Yeah, fix. Wait. Yeah, fix. Yeah. Hold. Yeah, fix. Next. No. Hold. Fix.
बस पुल कर ले
Yeah. Yeah, fix. And yeah, fix. Good. Okay. Rod. Mm-hmm. Mm-hmm. Yeah. Cut. Good. And we need in situ bender. Yeah. Yeah. Mm-hmm. Yeah. Oh, maybe we start here. Oh, maybe cut a little more. A little. Mm-hmm. Yeah. Yeah. Give me set screen. No. It's here. Mm-hmm. Cup. Mm-hmm. Yeah. Here. Screwdriver. Give me please.
Screwdriver then I didn't.
No.
Hello. OT4, you are connected, sir.
Can you hear?
Yes, sir.
So I want to show you how much gap there is in the so-called disk space. Can you see now? Can you guys see? Hello? Can you hear? Can you hear? Is the screen visible? So this is the L5S1 disk space, and actually in the front,
Yeah, we can see Dr. Rajkumar.
you can see the anterolongitudinal ligament at the here. Can you see?
Yeah.
So even in this case, and give me a straight dissect, straight correct. The doubt was whether there is movement, right? Whether it was fused, right? So I'll show you this. Can you hear?
Yeah, we can see.
Can you see the movement?
Yes, we can appreciate.
So it is not really fused. So I just put a trial cage, 8 millimeter, I can do it. You can show on the screen that we have put a trial cage. And then now what I'll do is I'll leave at this and go for the L45 because that's another fusion plan. We'll do a similar discectomy, facetectomy for L45, and then we'll do a pedicle screw fixation. That's the plan.
Sir, in case this was fused, what would be your approach? Would you have gone in and chiseled it out anteriorly?
That was not chiseled. I would have sort of broken it. I would try simpler thing. I won't do some crazy stuff, put a chisel there and all that. But
I can do it in my setup because I know how much I can go. In a demonstration case, I don't want to do that. Second thing is, somewhat I was sure that this would move, and therefore it has moved. In a completely ossified, not just calcified, ossified, well, you don't have to do anything, just do decompression.
Thank you, sir.
So I'll go to the next level now, okay? Thank you, guys. I can do that if you want. You have the cage ready, 8, and the bone. You can do that. Cage here. Do you guys have cage? 8. Oh, you wanted to see Sachin? Come. You can see now. Can you see the movement? I don't know about that. Let us try. I'll put the cage and we can start pulling it up. So do you want me to do L45 or you don't want me to do L45? What? $8.22. And give me the bone. Where's the bone? Let me start putting bone. Hold. If you don't want me to put, I will avoid. I can go straight away for a. No, trial done. There. We put, sir. Sachin is doubting what is this man doing, coming here and putting simply some muck inside. No, bhai. What happened?
Sir, I had another question. When would you think of extending it to S2 LR?
You're asking me?
Yes, sir.
See, in patients who are osteoporotic, adding another level is a insurance. Instead of S2, I would sometimes prefer to go to Ilium. Ilium screw, you can put a very long screw. S2 can be very weak. So S2 is something I'm not very comfortable. I would rather put a long, thick Ilium screw. Ilium has an advantage that it provides significant strength. Also in patients who are elderly, the SI joint will be getting arthrosed. So if there is any pain in that area, for whatever reason, the screw also aids in giving support. So iliac extension is when you think that the S1 substrate is not sufficiently strong. You need some? Does that answer your question?
Yes, sir. Thank you.
Iliac screw by MS can be tricky if you are not in the correct alignment. It can be done, but I would rather put that under open. Because aligning the heads under any condition will be tricky. I notice I'm putting it more anterior. I'm putting the bone anterior, right? Then the cage will go behind it. Let's see if I can get a reduction. I don't know how strong is the bone. Enough, that's enough. Have the cage. Hold this. Making it more loose, huh? Give. Should be okay. That's it, that's it. That man, it doesn't go. What? This is useless.
Please connect to OT-2.
But the odontoid has been now brought back into the center.
OT-2 you are connected, sir.
Patkar sir, you were showing some things?
Yeah, we are much better. You can see the lateral mass में screw बराबर जा रहा है, दिख रहा है ना? On both sides, the screw is going in the lateral mass and the odontoid is in the center. But the odontoid has been now brought back into the center. Now you can see. इसको हटाओ. ये image दिखा सकते हो क्या इसके ऊपर? Can you show this image? Dr. Agarwal, can you see this AP image?
Yes, sir, we can see it.
Can you see the screw go across the joint up to the upper outer border?
Yes,
on
sir.
this side and this side.
Yes, sir. One right side is clear, left side the image is not clear.
दिखा सकते हो क्या इसके ऊपर? Can you show this image? Dr. Agarwal, can you see this AP image?
Yes, sir, we can see it.
Can you see the screw go across the joint up to the upper outer? Now we'll show you the dynamic fluoroscopic view. इसका lateral करो.
One right side is clear, left side
अंदर करो.
the image is not clear, sir.
See, this is the lateral mass.
So in C1 lateral mass, it has to cross the bicortical purchase sort of?
No, there no need a bicortical purchase. They should have good adequate purchase. अभी जाओ पीछे जाओ अंदर करो. अभी हाइपर एक्सटेंशन में जरा इसको कम करते हैं हाइपर एक्सटेंशन को. अभी शूट करो.
C1 lateral mass, it has to cross the bicortical purchase sort of?
No, there no need a bicortical purchase. They should have good adequate. चलो आ जाओ पोजीशन में. अभी जाओ पीछे जाओ. पोजीशन में आए कि नहीं? अभी शूट करो. एक्सटेंशन में जरा इसको कम करते हैं हाइपर एक्सटेंशन को. अभी शूट करो. एक मिनट पोजीशन करने दो. एक मिनट उधर जाओ. शूट. हाँ चलो आ जाओ पोजीशन में. बराबर नहीं आ रहा पोजीशन. पोजीशन में आए कि नहीं? उसको निकालो ये आर्टरी फोर्सेप्स को. You do it आपने किया. हाँ you do it better than me. I have to see the screen also. हट जाओ सिस्टर. एक मिनट शूट. ये बराबर नहीं आ रहा पोजीशन. ओके उसको निकालो. स्टार्ट शूटिंग. Can you appreciate that there is no movement between the atlas and the axis? Have to see the screen also. Hello.
Yes, sir.
It is rigid.
Can possible to restrict the movement of subaxial spine to actually see the flexion extension at C1, C2, sir?
Normally when we do flexion extension exercise also we are doing the same thing. No?
Yes, sir.
It is
It is possible to restrict the movement
Correct.
of subaxial spine.
तो ये निकाल के करना पड़ेगा, ब्रेक को थोड़ा ये टावर क्लिप निकाल के पूरा फ्लेक्स करो.
Extension like C1, C2, sir.
हाँ, उठा सकते हो सिर को. हाँ, उठा, उठा. तो शूट करो. शूट तो करो. करेक्ट. तो ये निकाल के करना पड़ेगा, ब्रेक को थोड़ा. See, now we have brought the chin almost low down. अभी भी थोड़ा एक्सटेंशन ही है. हाँ, उठा. उठा, ऊपर उठा. उठा. तो शूट करो. हाँ. ओके, अभी शूट करो. शूट तो करो. See,
yes,
the spinal laminar lines remain in same line with the posterior arch of the atlas. Almost low down.
Yes.
Can you appreciate it?
Yes, sir.
Okay, extension करो. रोटेशन करो. ओके, अभी शूट करो. शूट करो. ये बाजू में रोटेट करो, दोनों बाजू में करो. शूट. वो बाजू में करो. शूट. करो बाजू में. शूट. करो और करो. हाँ, ये स्ट्रेट पोजीशन है. So now you see the posterior arch of the atlas bang in line with the spinal laminar line.
Yes, sir.
Can you appreciate it? This is the straight position. You can see these screws and you can see the posterior arch of the atlas with the spinal laminar line.
Yes, sir.
Okay? So operation is over. Thank you very much. Any questions?
Yes, sir.
Can you appreciate it? This is the straight position.
Hello. Yes, sir. We are very thankful to you, sir. We had a very nice understanding of the surgery today, sir. Yes, sir.
Okay.
Sir, I had one question.
Two questions. Not one, only two.
Post-operatively, how much of the rotation is hampered?
Totally hampered. Totally hampered.
Thank you.
That is the only movement in the atlantoaxial joint. The moment you fix the atlantoaxial joint, the rotation is gone. A good fixation means the rotation of the atlantoaxial joint should go. Now the rotation will be in the subaxial spine.
Post-operatively, how much
The atlantoaxial joint is only one movement, that is rotation. You understand what I'm saying? The movement in the atlantoaxial joint, the moment you fix the atlantoaxial joint, the rotation is gone. A good fixation.
Yes, sir, we understand, sir.
Yes, so if the rotation is not gone, that means the operation is incomplete.
So
the atlantoaxial joint. Like saying, I did abdominal perennial resection and the patient had children after that. That is not possible. Hello?
Yes, sir, we understand, sir. We understand.
Yes. After abdominal perennial resection, the person had children. That is not possible.
So, Doctor, I am back here, Dr. Patkar, Dr. Deepak here. So, any final comments?
Final comment, nothing. You should have an array of implants, you should have an array of instruments, and the technique is very simple. How much is the blood loss, doctor? How much is the blood loss?
So, Doctor, I am back.
Less than 50 ml blood loss. So,
yes, excellent.
There is no vertebral artery, no venous plexus bleeding, and your Vesalius cautery is fantastic. You know, Vesalius was the father of modern anatomy. And his cautery, I think, will become more popular than his textbook of anatomy.
Correct. So thank you so much, sir. I think the audience, I have got the feedback, people really enjoyed. They were asking why this technique has not been popularized.
The only reason is that the posterior C1, C2 fixation was described by people like Nagel and Figger and all these guys who are orthopedic surgeons.
Right.
Microsurgery came in by the neurosurgeons, and the neurosurgeons stopped short at the C3-4 disc.
Why this technique has not been popularized.
And they turned behind and did it from behind by tradition. I think it was by tradition. It's just like, when I started neurosurgery, there was nothing like Smith-Robinson period. There was only staggered laminectomy, and we used to open the dura and cut the denticulate ligaments.
Right.
And then I have even published a paper in Neurology India at that time of seizures with pneumocephalus after cervical spine surgery. Can you believe that? Can you get cervical after cervical spine surgery now? Seizures. We cannot, because we do it from the front.
Yes.
But it took few years for things to change from laminectomy, opening dura, cutting denticulate ligament to anterior fusion. Same thing will happen to this operation. You see the recent literature. It is my friend Professor Visochi who will make this popular. And here he is writing about this. Recently also he wrote about craniovertebral surgery, the evolution. I read that paper of his about the evolution of craniovertebral surgery. And in that paper also you have mentioned how the transition is taking place from posterior to anterior. Am I right, Professor Visochi? And here he is writing about this. Recently, is he there?
Yeah.
You had recently written about the history and evolution of craniovertebral surgery and how it has evolved from posterior to anterior.
Good question. You know that there are in the United States and the UK they say many ways to skin a cat.
Yes.
That means that you can get the center of a ball by a different way. The problem is that the head and the cervical spine is not a ball, and is an asymmetrical issue. So I think that the great advantage of posterior goal fixation is the invention of something new at that time, but with the risk of blood loss, significant blood loss, the risk to damage C2 root, and the risk to deal with vertebral artery close to the surgical target. I had a case of vertebral dissection without hemorrhage, but with ischemia, fortunately compensated by contralateral feeding. The advantage of anterior approach that you so successfully shown us is that the surgical the surgical domain is cleaner compared to the posterior one, less blood loss, wonderful control of C1, C2 joint. Vertebral artery is quite far lateral compared to the posterior one. On the other hand, we have two drawbacks, two risk, theoretically two risk. Number one is the nerve apraxia of hypoglossal nerve that we have to shift per at least one half hour with the spreader. So this is a significant risk. We have also the risk that we can produce a stupor of the superior laryngeal nerve with postoperative dysphonia. Sometimes you can restore it, sometimes you cannot. I think that your approach is just the modified McAfee approach, like the one that I yesterday described and today I have to underline again. So our approach is quite the same. The unique the difference is the skin incision. That is longer in your case, a little bit shorter in my experience. But to make a longer skin incision allow the possibility to shift deeper tissue during the operation and to gain more access to the craniovertebral junction. So again, many ways to skin a cat, different strategies to choose posterior instead of anterior and vice versa, some trick and picks in each one of us experience. I think that the final result is brilliant, and you fired in me many ideas in this moment to add something more. I will explain as I concretize my idea when I return back home, and so please keep in touch for the future. Many ideas in this moment.
Very much.
Thank you, Dr. Patkar.
Thank you.
Add something more.
So we shift to OT-3, Dr. Park.
As I concretize.
He's putting in the
my idea when I return back home, and so please keep in touch for the future.
Try to the hemoclude, yes, but there are some difficulty, impinging root, and it is not easy to clip in. So we are trying to patch.
Okay.
trying to patch and try to the glue instead of we remove the tumor successfully. We remove the tumor successfully, but we have problems to the closing of dura. So we try to clean like this.
Right.
But the inferior part here, it is impossible to try clean like this. So we are trying to only dressing here and apply the glue. This is a small defect of dura.
Yes.
Actually, I wanted to try clean like this, but this is root. This is root. This is root. So I'm trying to the glue over here.
Okay.
Yes. Okay. So let me explain. Yeah, we remove the tumor. Total remove the tumor mass, and try to close the dura here, but this defect is very difficult and some dangerous to close. That's right. Before injection of glue, we have to dry up.
Dry them.
Yes, for the maximize the effect of the glue. To prevent dilution of glue, it's okay. Glue first. And when I put here, okay, and close, okay, try, close, everybody close, okay, try, what's your, okay. Okay. So, cotton line, please. It's okay. And it will be too big. Okay. Open. Slowly. This is a post image of post apply.
Yes, we can see.
Yeah. Are you ready? That's okay?
Yes, it looks okay.
Okay, 그럼 타코스 please. Okay. 써주세요, 타코스. Packing in. Okay, no more glue. Your opinion? No more glue. One more glue. One more glue. Okay. Wait for one more glue. Close.